call this meeting to order. Approval of minutes included in your packets are minutes from the January meeting of the Commission and minutes from the February 6th meeting via teleconference. If there are no objections, I'll entertain a motion for approval. Second. Liz?
For the February 6th, 2017 meeting, and my name is not on here, so just to make that correction.
Okay, we will make that correction. Yeah, sure. Any other additions? All in favor of approving the minutes? Aye. Any opposed? Minutes are approved. Commissioners, you've received a written update from our center. Do you have any questions on the written update? And Ben, do you or center directors have anything to add?
I have several updates that I wanted to share with you. On Friday and Monday, the commissions had their budget hearings. For our budget hearings, MHCC, HSCRC, and the Community Health Resources Commissions all appear before the respective committees. The commission's operating allowance from the governor in 2018 is $15.1 million. That's an increase over what we had proposed of 14.6 because of an adjustment that DBM is making in our indirect allowance. It's not going to lead to any additional activity, but DBM has determined that we should be paying a 30% indirect cost factor as opposed to an 18% cost factor. We've pointed out to DBM, and DLS concurred that the indirect factor was established in statute. So during the presentation, we outlined the issues. The Department of the Budget will have to decide whether they make a change in the Budget Reconciliation and Funding Act to allow them to increase our indirect costs. Both HSCRC and MHCC made the point that we had negotiated this indirect cost factor more than a decade ago based on a recognition that the commissions took on additional activities here that would offset costs that would otherwise be absorbed at the department. There was some understanding of that, but it also is important, I think, to keep in mind that the additional revenue that's sought from the commission is in response to an overall budget shortfall that DBM is trying to close, and we'll have to wait and see if they elect to seek a amendment to the what's called the BRFA, the Budget Reconciliation and Financing Act, to raise our indirect costs. This would have somewhat of an impact on the commission in 2018 should this go through. Some of the questions that also are asked is, how is the commission operating given that our cap had not been raised since 2008? I did point out that in 2018 we believe that our $12 million assessment in conjunction with our $3.9 million projected reserve would allow us to meet our budget for 2018, but absent any reductions, any increases in revenue from either changes in the cap or from other revenue sources, that in 2019 we would be seeking a mandate reduction to formally reduce the volume of work that we had to undertake to account for the funding level the commission would have. There were also several questions pertaining to the commission's ability to work together, particularly as it related to the progression plan on the new all-payer model. Both HSCRC and MHCC outlined areas in which they were taking on responsibility. My focus was, in terms of current activities, to focus on work with our partners at CRISP in terms of rolling out some of the very significant information technology activities that are to support the waiver, as well as sharing of quality and quality and cost information through our quality measurement tools, as well as our activities in making the APDD, the medical care database, available to HFCRC. And then I outlined visions on what the Commission's role would be in the progression plan, which focuses on our activities related to the Maryland Comprehensive Primary Care Model. There were also questions about the activities broadly framed under CRISP, the Integrated Care Network. David Horrocks and Center Director David Sharp have talked about that in the past. In 2018, that initiative will account for about $25 million in spending taken from what was formerly the Maryland Health Insurance Partnership Reserve that was transferred largely over to implementation of the ICN. The ICN is a set of 7 work streams related to information technology that are designed to support the expansion of the all-payer model. They include activities such as the cost of connecting community-based providers to the information exchange and enabling them to send, receive, and use information shared over the exchange. It also includes a more enhanced what's called a data router, which is the interface that would enable information to be shared among providers, as well as giving consumers ability to define who and how some of their information is shared. Today on the HIE, patients have a binary choice, either opt in or opt out of the exchange, but as we move forward, the intelligent data router would allow patients to have a more specific ability to frame what's shared. Work would also expand on what's called the CRISP clinical portal. Much of that focus today is really on making that portal accessible to clinicians through features such as single sign-on, which makes it much more transparent to clinicians in terms of information they receive from within their own organization and beyond. And one of the bottlenecks historically has been that you have these separate activities, work within your own environment, and then log on to CRISP to access information in the broader network. Greater work is going to be done on alignment, reporting, and analytics will be expanded. Additional features called care alerts are also slated to be expanded, as are work on development on a very basic care plan. Typically, many of the more advanced systems have care management tools embedded, but some of the systems, and certainly many community practices, don't have that feature. And it's envisioned that CRISP would award a contract to a vendor that would make a basic care plan feature available. And then lastly, through their activities through this broad venture, this 7th work stream, is CRISP would be engaged in supporting care transformation, which from their standpoint means making additional information available to practices to better deliver patient-centered, high-quality care. Altogether, 7 streams. They're couched in the term of Integrated Care Network, which doesn't mean too much to anyone, but given the legislature's interest in this, given that it's a significant venture, this is directed largely by HFCRC. MHCC does control the budget for the project, and we release funds. We also have a significant role as the designator of the HIE. I see in the next year that we're going to bring forward progress on this on a more frequent basis, as it's a high-stakes technology effort run by Chris, a very trusted enterprise, but certainly very ambitious. David's been taking the lead on this, but as we provide additional funds, I think on an ongoing basis, I want all of the commissioners to be more aware of what's going on this important endeavor. It is it's essential to the next phase of the waiver and will support clinicians in their ability to deliver integrated care across all care settings. The other announcement that I wanted to share with you is that we have signed a grant agreement with the Network for Regional Health Care Improvements. This is the third phase of continuous work that Linda and her team started last year. And Henry is expanding the initiative to 12 regions in 2017. We are participating at a little lower level than we did last year. We are part of the group of organizations that are in the alignment initiative, which will mean that we will contribute, we will participate and provide, calculate total cost of care metrics that will be used in Henry's national benchmark effort. Last year, as you recall, Maryland was scored relatively favorably compared to the other 6 regions that participated in that initiative. 6 other regions are participating more aggressively, and they're not only doing the national benchmarking enterprise, but they're also participating in the physician and community engagement aspects of the initiative. We looked at that and noted that the amount of funds that Henry could make available to carry that forward was not, we didn't believe, adequate for the level of effort they required. And so although we're particularly interested in the provider engagement aspects of this, to formally commit to marching along with Henry on that aspect of the program, I think is beyond the capabilities of our current budget. Put another way, we invest $2 of effort for every $1 in grant funds, and we were fearful of the consequences this year. So I think we're being a little more cautious. The total cost of care comparison metrics are extremely valuable for benchmarking purposes, and we intend to work to the extent we can with practices in making the total cost of care metric available, but the commitments they wanted may be a little beyond our reach. The last point I wanted to emphasize, we continue to work on the comprehensive primary care model with colleagues at DHMH, and we also are now engaged in some conversations with staff at the Centers for Medicare and Medicaid Services, specifically CMS. As you know, the Maryland comprehensive primary care model was proposed by Governor Hogan at the end of December. That program has not been approved, but there is effort moving forward in working out the details of and adding additional clarity on what the program would look like should it be rolled out in 2018. The focus, of course, is that this mirrors something that has been going on nationally in 14 regions. CMS is expanding it to 10 additional regions over the next 6 months. And the Maryland model really reflects additional flexibility the state hopes to offer to Maryland providers that would choose to participate in the program. So it's beyond what the existing 14 regions would get to implement. And there will certainly be back and forth before any sort of closure on this program is reached. It will require CMS and Maryland sign off at the highest level, but we are participating in those discussions. that concludes my update. Happy to answer any questions.
Questions for Ben?
I just have one. This is on page 10 of the update, staff update. We're joining with the University of Maryland and some other partners to submit a proposal to the Patient-Centered Outcomes Research Institute. We're looking for $5 million, right? What is the proposal that we're I mean, it's looking from the report, it's not clear what the proposal is. But,
So this is a refinement and resubmission of an application that was put forward last year in January. That proposal was not accepted. If David would come up and briefly outline the nature of the project. It builds on some telehealth grants that we previously had completed. But David, why don't you fill us in?
Good afternoon, Mr. Chairman, Commissioners. Dr. Moffat, thank you for that question. We are partnering with the University of Maryland and Lorien Health Systems on a grant. We chase grants, and this was an opportunity for us last year. And with PCORI, there is a requirement to do a letter of intent. So the letter of intent, the model really is testing the efficacy of using remote patient monitoring on patients that are discharged, as opposed to using care coordinators in the field as purely monitoring the post-discharge activities. And testing in those two scenarios using very similar demographics in two counties, Howard County and in the Bel Air in Cecil County, looking at the outcomes to see does using remote patient monitoring actually improve patient outcomes, patients fare better, as opposed to a model where they're using clinical care coordinators in the field on post-discharge between 30, 60, and 90 days. And what's the impact on admission?
excellent idea. Thank you very much.
Great idea. Thank you.
Other questions? Center directors, any updates? Linda Bartniska, you have a staff member, and an update to Dr. Pollack's question from last time.
Good afternoon. I have actually two really important events to bring you up to speed on. And the first is we have a new division chief that joined the center 2 weeks ago, Mahi Nagatu, and I've invited her here to tell you just a little bit about herself and why she's come.
Thank you. Good afternoon to you all. As Linda mentioned, my name is Mahalit Nagatu, in short, Mahi. Today is the beginning of the third week for me here at MATC. Before coming here, I was with Wisconsin Health Information Organization. That's a voluntary APCD with the state of Wisconsin. I was there for 2.5 years, and I was a senior data analyst and a BI developer, wearing many hats. I developed and was responsible for deploying analytic products involved in various research projects. I was overseeing the Medicare data process compliance with for the state agency and qualified entity routes. I was also responsible for the operation and management of the WEO Health Data Mart data warehouse and developing business rules, design, and development of the WEO provider registry. Prior to that, I worked for HRSA, Health Resource Service Administration here in Rockville, for more than 5 years, where I worked on my master's in health information technology. Me and my husband moved here from Wisconsin when he accepted a position at Johns Hopkins Armstrong Institute for Patient Safety and Quality. I was familiar with MATC's long and distinguished tradition of engaging public and private sector in healthcare policy and regulation. So when the position was announced, I was very excited and applied for the job, and I was offered the position. And I'm really excited to be here, and I look forward to working with everyone and really learning from the wealth of experience here. So, thank you.
Thanks. Welcome to Maryland.
My second update before I get to the last question is to let you know that we have been able to execute our data use agreement with Johns Hopkins School of Public Health, which you may or may not recall. A part of our campaign to get the database into more wide use is to create, with the two schools of public health in Maryland, a multi-use data use agreement that enables them to vet their own studies, for which they don't have to come to us for every individual study, that they vet their own studies. It's using their institutional review boards. Every study that's conducted by a student has to have a faculty member. Really strict protocols. It took a long time to work it all out, so everyone was really comfortable. But they already have 4 years of data. They'll get 2 more years of data, and they have 2 years of having the data for free to see if it's worth their while to pay for the data, continue to use it, and we're really excited about that. And I want to say immediately that now we have the template all worked out. We'll be negotiating similarly with the University of Maryland. It should go much more quickly because the template is established, and we'll be more than happy to have them using the data as well under the same agreement.
So just a brief comment. Thank you very much for the update. And interesting enough, earlier this week, one of the grantees of the commission, the Totally Linking Care Coalition in Prince George's County, this is a group of all the hospitals in Prince George's County and in southern Maryland, received an award from the commission to look at improving care. And they came to us for assistance. And it was very clear that collaborating with the all-payer would be a way of enhancing their data stream and their outcomes. So it also means that in the future, if there are other grantees, that it can be either built in as an expectation that you work with one of the all-payer providers so that we can really get that kind of added value. So we're looking forward to this new agreement will be quite helpful.
Okay, great.
Diane?
So this is great news. To know that the work of the commission can bring more value to understanding of healthcare, but also, frankly, more value to the field in general. Does this agreement include any report back to the commission in terms of the types of research that's done and also the findings, frankly, so that we can use it, the commission can use it in elevating the value add that having the all-payer data brings to the state of Maryland?
So one of their requirements for the schools is that they must report quarterly on who's using the data for what, and then when studies are completed to let us know that so that we are aware of those things, and we can put those in the monthly updates for you all to know. I'd be happy to do that. And you had one more question. I think did you want me to update Dr. Pollack or?
Yes, they're around the changes in access to elective surgical services.
Yes.
After the 2014.
So at Commissioner Pollack's request, staff conducted a simple analysis using our hospital discharge data, using the APR-DRGs for hip replacements, knee replacements, and 2 spine procedures to see what the trend was between 2012 and 2016 for different payer populations in terms of inpatient utilization. We did complete that, and we will make it available to all of the commissioners. There's a spreadsheet that you're more than welcome to play with. It includes a set of graphs so you can see the contrast. You'll notice on the graph that we included the commercial population so that you could see what the background trend was. And then we have a Word document that gives some caveats that includes that this is really only the inpatient hospital setting, and we probably want to add the hospital outpatient setting so that because some of these procedures are done there as well, and that we may want to include some member counts so you get some per capita. But we thought we would show it to you and get your feedback before we proceeded with the next set of analyses, and those would be posted on the commissioner page for you to view and comment on.
And what were the high-level findings?
So I would say, except for one spinal procedure, there was no discernible, well, actually two spinal procedures, but there was no discernible downward trend for the hips or the knees. In one of the spinal procedures, which I can't remember which one it was right now, but there was a distinct downward trend from 2012 to 2016 in the commercial population. But again, we're not certain if that's because where the location of the procedure is happening has migrated to different settings. But that was, you could definitely see that. And then in the Medicare population, starting in 2014, they had a similar downward trend. Again, it could be movement to other locations. And then in the second spinal procedure, there was a little different, less of a downward trend, but a little downward trend in the privately insured population. Again, I think possibly because of migration to other settings. So we will, if you all could look at that and then give us some feedback on where you'd like to go with that, and we will push that forward so that you could potentially use it as a monitoring tool.
Perfect.
So thank you very much for putting that online. Just to refresh, memories. The concern is that in the context of a global budget system, the incentive to continue to grow volume on the part of hospitals, even good volume, necessary utilization of care, goes way down. And when thus the access potentially goes down, the access to care for individuals. And when access to care goes down, then the first populations that are affected are the most vulnerable populations. And so to me, that's the Medicaid population, the MCO population, and it'll be interesting to see how they compare over time. Obviously, the raw comparisons are one thing.
That's right.
You have to adjust them for transitions to outpatient, but really also have to adjust them for changes in the relative age of the population and what you would expect in terms of utilization.
Correct.
It's hard. It's only since 2014 that GBR has been in place, so it's not unreasonable to think that there's no change between 2014 and 2016. But we certainly know from other models worldwide where this type of a system has been used that is what happens. That's the risk. And continuing to monitor this population long term is the due diligence that's necessary to engage in this type of an experiment in population health management.
Right. And so I think that because we know that's true, when we talked, Dr. Hollick and I spoke, we were looking for a relatively simple, effective way that we could continue to monitor this for you and provide you with those results using our own resources here within the Commission.
So, Commissioner Pollack, I have a question. I have some of the hospital systems, for example, in Prince George's County, being incentivized, as you're describing. And one of the things that they're doing is driving their clinical services out into the neighborhood, out into the community. So I guess my question is, when they're engaging these very vulnerable populations, as we're talking about, out in the neighborhood, in the community, be it a church, a barbershop, or some other non-hospital setting, are they hospital patients? Do they show up as hospital patients, even though the care is being delivered by the hospital staff?
No.
So this could be an anomaly in the sense that they're driving services into the neighborhoods to prevent unnecessary readmissions, which then goes back to your point. You're not driving volume in the hospital.
It's a little different because this is looking purely at elective surgical volume. And the services out in the communities are really designed to get at potentially avoidable utilization, which is typically readmissions for diabetic complications, congestive heart failure, more primary care concerns. This analysis is really focused on the elective surgical concern, which behaves differently. Now, it may be that reaching out into the community in this way brings people into the health system in ways that they otherwise wouldn't be in, and may offset in terms of the way that it provides, in terms of what it does for access to care. But at the end of the day, the bottleneck, just looking at it from an operational standpoint on a day-to-day basis, is access to operating rooms in hospitals. And that's the piece that doesn't seem to be as aggressively moving. within hospital systems, and because there's no incentive to do it anymore.
Fran?
Yeah, I think thank you for that response to Commissioner Pollack's question from last month. And I think we need to kind of rise up above this particular inquiry, which was to look at discretionary orthopedic procedures with the intent being to monitor unintended consequences of a very well-intended model. So we have this model to avert unnecessary utilization, to provide better care in community settings. But an unintended consequence of the financial incentives could be, hypothetically, less discretionary care, shorter length of stay, non-admissions for individuals who really did need to be admitted to more acute. So how to get a handle on that kind of broad, what would be the indicators to monitor that kind of a consequence? I think it's a really serious question, both for this commission to grapple with as well as HSCRC.
I will say that HSCRC has a very complicated total cost of care matrix, where they really are looking at where the services are provided in the continuum for the different payer populations. And for example, Medicaid provides lots of information to them on the volumes and where the volumes are. And I will say, I do think we all know that there is something to be said for having services move to the least expensive venue in which they can safely be provided. So I think there is some desire to see more, services provided in the most cost-effective manner. But we do want to, so they have captured that in their window, and they're following certain things in detail. Not, I would say, not individual procedures that Dr. Pollack was interested in, but if we think of these as sort of canaries in the coal mine kind of procedures, I think he might agree that we don't have to monitor everything in order to be able to know if there's a problem.
Yeah, exactly. I mean, obviously, I see the world from an orthopedic lens. I get that, but we know from the Canadian system that those were the markers of when the line started to develop, was in hip and knee replacement. We know that population is getting larger, faster. The need for those services are growing. So it seems like a good marker. And if you look at where the large buckets of expenditure are for CMS in their insured population, it's hip replacement, knee replacement, cardiac surgery, and spine. So those are good markers. There may be others also, but
and you may suggest those, right?
I think it's important that we at least begin with some markers and then expand.
Other questions or comments?
I just had a comment on, I guess, a comment on following up. Would those be the same markers for a commercial population that's under 65, or would you need to sort of develop a whole separate set for the under folks?
I'll take that. It's because the hospitals have the APR DRGs, so that the same description of the surgery is identical for each of those payer populations. And so you'll see that, it's how this is defined and if this occurs in the payer population. There is some information on the under 65 and over 65 in the spreadsheet, but there wasn't, almost every payer, the vast bulk of their enrollees, commercial under 65, Medicare over 65. So the numbers are sort of combined in the graph you'll see, just so you know that. But there's a lot of information in there that you can look at. And there are different payer populations. But the key ones were Medicare, Medicaid, and then the commercial. But you'll be able to see on the table all the other populations that the HSCR discharge data tracks. So if you're interested in any of those, we can look at those as well.
Okay, thank you. Any other center director updates?
Forget it.
Bye-bye. Okay. All right, let's move to agenda item number 3, which is CON approval for Lorien Elkridge. They seek approval to add 25 comprehensive care facility beds and construct a 3-story building with minor reservations to the existing facility. And Kevin will present the staff recommendation.
Thank you and good afternoon. The applicant is Lorien Life Center Howard II Incorporated. I'll refer to them as Lorien Elkridge. They opened in 2012. They currently are operating 70 beds. Their quality record is about average, meeting or exceeding the state average in nursing home performance on 7 of what we've identified as 13 of the key quality measures, and ranking lower than average on 6. The bed occupancy is 91% over the last 2 years, a little bit higher than the jurisdictional occupancy in Howard County. The project would be a almost 20,000 square foot addition with a renovation of about 1,500 square feet. Would add 25 beds, and the nursing home would consist of 95 beds after the project. Total estimated cost is $5.46 million. It would be funded with a mortgage loan of about $4.25 million, $900,000 in cash, and a $300,000 loan. Looking at the project vis-a-vis the key considerations in our standards and criteria, on balance, the quality track record of this facility is average, measured against, again, the key quality measures that we've identified. On the other hand, the Lorien family of facilities, of which this is one of 10, has a strong track record. The net need, in effect, in the jurisdiction is 105. The facility occupancy is strong, and the jurisdictional occupancy in Howard County has built up to 89% after at least a 4-year stretch where it averaged under 84%. The impact on other providers is likely to be minimal, given the strong current occupancies of the other facilities, the fact that this project would increase supply in the county by just about 4%, and that the county is aging faster than the state average. So we don't think that there's really going to be any impact on other facilities. From a viability and financial feasibility standpoint, the facility has had a positive bottom line, made reasonable assumptions on its payer mix, occupancy, and projects a positive bottom line going forward after project completion. In terms of availability of funds, there is a letter of interest from M&T Bank indicating an existing relationship and an interest in financing this project. And we also have a letter from Michael Snarsky, a CPA who has testified on previous Lorien projects, stating that the Mangione family members have the financial resources to fund this project. To recap the staff recommendation, the project would be consistent with Healthcare Commission need projections. The facility occupancy is high. The jurisdictional occupancy is healthy. The applicant has reasonably demonstrated that the project is viable and has a strong track record as a nursing home operator. Staff finds the proposed project to be in compliance with the applicable criteria and standards and recommends approval with 2 standard conditions that we attach to recommended conditions that we attach to nursing home project. One is that they execute a memorandum of understanding with Medicaid to participate at the level in the regulations, and that they shall meet and maintain the minimum proportion of Medicaid patient days required by the nursing home standard going forward. With us today are representing the project their attorney, Jim Forsythe, and Michael Snarsky, financial person in their organization.
Can I get a motion to approve the CON? Second. Let's open it up for discussions and comments.
Just two comments. I'm always amazed at the new construction price that folks are paying for beds at over $200,000 a bed for the expansion there. But it's our money, so so be it. The other thing I wanted to note is, compared to some of the other CONs we've come before us, their payer mix seems to be more in line with what is traditionally being seen, with around 25 or 30% Medicare mix versus some of the other ones coming in with 40 or 45%. So that was encouraging to see, because that's, in my opinion, more realistic. So I just wanted to make those two comments.
Thank you. Other questions or comments?
I had a question about you mentioned the quality being about average, and I guess it was just a question of how we analyze that in terms of need. About average just means it's sort of in line with other facilities in the state. Is that a good thing? Like,
Actually,
averages are high, that's fantastic, or is it a bad thing because it's only average and the quality is poor? Or are we looking, when we give out a certificate of need, are we looking for average or better, or average or worse? So it's not really a question about Lorien as much as how does the commission usually use that information?
Actually, our current standard is we've provided more information in that quality write-up than the standard requires. The standard is only that they don't have any open level deficiencies above a certain level, pretty serious level. What we thought would be of more interest to the commission would be measurement against some of the key standards in the Medicare and the state measures. They're better than average on 7. They're a little below average, or somewhat below average on 6, which is why I say average. If you look at the chart in the report for all the Lorien facilities, you'll see that generally their family of nursing homes does better than the state average.
So, what we've applying the standard, what we're really looking for is qualifying things rather than achieving a certain measure.
Okay. I think that's a good way to put it. Yes.
Thank you.
But in the spirit of trying to interpret the state health plan, I think a lot of times, sort of historically, the commission has wanted the staff to kind of go beyond.
Oh, sure.
What the state health plan has done, especially in quality. I can recall several conversations around that. So I think staff has tried to be really responsive to that.
Yeah, and absolutely, I'm not being all critical. I was just trying to figure out how I should be evaluating and applying. Yeah, thank you.
Yes, you have a.
I just wanted to address that quality issue. The facility had a bad survey last year. The facility had what it considered to be a bad survey last year, and that's what carries forward with the findings referenced in the staff report. I'm happy to tell you that the facility and by the way, people lost their jobs over that survey because it's not acceptable to the Mangione family. New director of nursing was brought in, etc. I'm happy to advise the commission that the facility just finished its 2017 annual survey, January 23rd through the 25th, while last year's bad survey showed 11 deficiencies seriously. This year's 4 minor deficiencies, 3 of which related to cracks in vinyl seat coverings, which you may know causes problems for infection control, disinfecting vinyl. Only 1 related to patient care, in which a resident removed a breathing mask while on the way to the bathroom. And plans of correction have been filed or are about to be filed. So I didn't want to leave you with the impression that this is an average facility or substandard. All issues were immediately addressed, and as Kevin pointed out, the Mangione facilities have it's actually an average of 3.77 stars on the Medicare survey.
vaccination rates were underreported. We discovered errors, and MDS coordinator, director of nurse and admissions people were counseled, and I'm happy to report that as of the most recent report, which is fourth quarter 2016, the overall vaccination rate, and Dr. Pollack, I know this was of concern to you, in September 2015, is over 96%. So they take quality of care very seriously.
Thank you. If there are no other questions, we'll call for vote. All in favor? Aye. Any opposed or abstentions? You have your CON. Move to a discussion of the state health plan for facilities and services, the freestanding medical facility proposed regulations. As you recall, in the January meeting, I informed commissioners that we were going to delay action on revised proposed freestanding medical facility regulations to permit discussions to occur amongst a number of parties around the exact regulations. Staff has informed me that the proposed regulations have now been modified to allow for greater flexibility in the scope of services that are offered at the freestanding medical facilities that would result from a conversion of an acute care hospital. The proposed regulations today that we will consider contain revisions and updates to proposed regulations that were adopted in November. You can see those as they were just sort of striked out and marked in the text. And Eileen Fleck will present the staff recommendation.
Thank you. Good afternoon, Mr. Chair and Commissioners. There are several changes that staff included in the draft health plan chapter for FMS as compared to the proposed regulations in November. These changes include making minor corrections and updating statistics in the issues and policy section, as well as substantive changes that primarily stem from reconsidering comments from the University of Maryland Medical System. So in the comments submitted in October of 2016, the University of Maryland Medical System stated that future freestanding medical facilities should be allowed greater flexibility in the application of the guidelines from the American College of Emergency Physicians for hospital emergency departments and freestanding emergency centers. These guidelines inform staff's determination of the number of treatment spaces needed for a freestanding medical facility, the size of the freestanding medical facility, the number of observation spaces needed, and the size of the observation spaces needed. Staff's recommended changes would allow an applicant to demonstrate why the low-range hospital guidance for emergency departments should not apply based on particular characteristics of the population to be served by the freestanding medical facilities, rather than requiring that all proposed freestanding medical facilities be consistent with the low-range hospital emergency department guidance. The University of Maryland Medical System also commented that surgical services at a freestanding medical facility should not be separately licensed as an ambulatory surgical facility, even though current licensure standards for freestanding medical facilities would not allow this. In response to this comment, we've added language to section 0.04C to account for the possibility that in the future, the licensure of freestanding medical facility may be expanded to include a wider range of services, including specifically surgical services. And so changes to the licensure regulations would not be within the scope of MHCC, but we did want to again allow for that possibility. Because surgical services may potentially be provided under the license for a freestanding medical facility, rather than at an ambulatory surgical facility, we concluded that other standards for the evaluation of an exemption request to establish a freestanding medical facility should also be modified. Previously, we expected applicants to provide utilization, revenue, and expense projections that pertain to the provision of emergency services and observation services. We've added language that references a broader array of services, specifically outpatient services provided at a freestanding medical facility that HSCRC has the discretion to rate regulate. We also added a new standard in section 0.04C because we concluded that the operating room utilization standards that are in COMAR 102411, the State Health Plan chapter for surgical services, should be used to evaluate whether proposed operating rooms in a freestanding medical facility will likely be efficiently utilized. The facility design requirements for proposed surgical capacity in the State Health Plan chapter for surgical services would also be applied. And when staff updates the State Health Plan chapter for surgical services, which we're working on currently, the applicability to freestanding medical facilities would be explicitly stated. Staff also added language that explicitly states that applicants proposing outpatient services that HSCRC has the discretion to rate regulate must receive a determination from HSCRC on whether they will be getting rates for those services, and the applicants need to receive approved rates for these services before staff would consider an applicant's request for an exemption complete. This information is needed in order to accurately evaluate the financial projections for the freestanding medical facility. Another change that staff added is for CON exemption requests is in section 0.04C. We decided that it should be explicitly stated that the projected financial performance of the parent hospital of a freestanding medical facility or both the parent hospitals and other healthcare facilities that share a common global budget will be considered in determining whether or not the conversion of a general hospital to a freestanding medical facility is in the public interest. Although an applicant would potentially address that issue as part of its demonstration that the conversion of a general hospital to a freestanding medical facility will result in the delivery of more efficient and effective healthcare services. In another standard, it was not specifically mentioned as part of that standard. Those are all of the changes that I wanted to highlight for you. I'd be happy to answer questions at this time. If there are not questions, then I would ask that the Commission adopt COMAR 1024-19 as proposed permanent regulations.
Let's get a motion first to approve COMAR 1024-19. Second. And let's open it up for discussions or comments, starting up here. Yes, Gary.
Actually, I have a bunch of questions. On page 11, it mentions that the development of FMF is an alternative to a general hospital. Who determined that, if that's a proper alternative to a general hospital? Since we're comparing this FMF, which seems to have evolved and morphed into a certainly different entity than what FMF was initially started as, which was to relieve emergency rooms of overflow. And now we're creating this facility that has operating rooms, observation beds. I'm not quite sure what this entity really should be called. Maybe we should rename it something different. But the first question is, I don't believe it's a great alternative to a general hospital. You're eliminating inpatient care with a facility that has no capabilities for inpatient care. And is there a distance requirement for an FMF to be from a acute care hospital?
I think with Medicare regulations, it does need to be within a certain number of miles, and it needs to be the primary place that patients are transferred to. Like, there needs to be that close relationship with the parent hospital.
Do we know how many miles that is?
I thought it was around 35 miles, potentially.
Okay. I talk about these observation beds. I'm not quite sure who's going to occupy these observation beds. Are these people waiting to be transferred? Are these people with a diagnosis that might get better overnight? In other words, do they need a subspecialist consultation to see them, as opposed to the ER doc being competent enough to watch, like, let's say, a GI bleeder that they're just observing? Does it preclude getting consultations from subspecialists? That's another question I have.
It doesn't, to my knowledge. I think the idea is similar to at a hospital where the staff is trying to determine if a patient should be admitted. It would be limited to 48 hours. So there would be a time limit as to how long the patient can be in observation.
I know my question is, who does the emergency room physician qualified to take care of a situation or diagnosis where a subspecialist, like a surgeon or a pulmonologist or a cardiologist, would be better off monitoring these patients? In other words, you're kind of saying, let's have all the requirements of a hospital without having a hospital. I don't know if you'll have all these subspecialists hanging around if there's no inpatient care, in other words. And I'm not sure ER physicians should be taking care of patients in an observation bed who might do better either being admitted to that hospital or being seen by a specialist.
I would say that the opportunity to have the observation beds was established in statute, that it's not affected by our regulations. It's not something where I would say we're taking a position on that. It sounds like it's something that licensure would maybe have standards in terms of what's appropriate.
Okay, and there's a question about if this is in the public interest. Who decides if this facility is in the public interest?
That's something that this commission will be considering. It's as part of converting from a hospital to a freestanding medical facility, there would be a public hearing. There are certain standards laid out, and so we would have that feedback. That's part of the information that we need before making a decision what the public feedback is.
And also the phrase that it must be more efficient and accessible than the system that presently exists. Who decides that? Do we decide that too?
Yes, that's a standard that the commission would weigh in on.
Okay. Thank you.
So I want to thank you for the tremendous amount of work going through these regs more than 2 or 3 times to kind of get to where we are right now. I think to answer some of the questions and to help understand how we got to where we are, it was my understanding that the committee's intent, the legislative committee's intent, was to create a mechanism for hospitals to transition facilities that would otherwise be closed into facilities that could continue to deliver some subset of services to the community. The initial version of these regs sort of envisioned that some subset of services to the community would be limited to an emergency department, and perhaps some observation on top of that. The committee's intent was that it would be as broad as could possibly be delivered in the context of a smaller footprint. The law allows some gap there. And this is sort of intended, where we are right now, is sort of intended to come a little bit closer to at least what Chairman Middleton told me was his interest in the piece of legislation. I think it's important as we start to develop this first set of regs in a piece of new legislation that we sort of, as a commission, have a good sense of that. And I think we have a better sense of it now than we did in November when this first came through. There are still issues with the operating room that are going to be problematic. The transition from a hospital operating room to an ambulatory surgery center is not only limited in the bed capacity around it, but Medicare has specific rules around what kind of procedures can be done in an ambulatory surgery operating room, which can be done in an inpatient operating room. It really doesn't describe what happens in an ambulatory operating room that's attached to a 48-hour facility. So we'll have to continue to work through those things. But I think, like anything, as this will be a work in progress, and as different facilities open up with different footprints and different models, we're going to have to maintain some level of flexibility and understanding that our goal is to encourage innovation in ways that can remain safe. To answer Dr. O'Connor's question, the way some other facilities, and I've recently looked at the Kaiser facility as an example of how this can happen. Patients come in with things like ankle fractures or appendicitis, and I recognize the whole world is not a surgical diagnosis, but the important parts are. But they come in with a diagnosis like that. They get seen the next morning by a specialist, just like they would in the context of a hospital, taken to the ambulatory surgical facility for treatment, and then kept for observation for a day or two. It's a group of physicians who take care of them, not just emergency department physicians, which is why it's a freestanding medical facility, not a freestanding emergency department. It requires integrating all those services together in a new way. We figured out how to do it in the context of hospitals. We'll have to figure out how to do it in the context of other things. But I think it's important for us to recognize this fundamental question that we were fighting with before, and that is that in certain markets, it's just not financially viable for hospitals to stay alive. And one option is to close down, just to shut down completely, and move those GBR dollars to other facilities and to take care of those patients at a greater distance. And this creates, or is intended at least to create, that additional option to continue to provide services to that community, in that community, at a substantially lower cost. and in a more cost-effective fashion. There will clearly be examples in doing this where we do a great job of decreasing costs and potentially improving quality of care, and there are clearly going to be examples in doing this across the country where things get worse and need to be fixed. But we need to be flexible enough in the way we design the regs, interpret the regs, and license these things to allow that type of innovation to occur.
Thank you. Hold on, we're going to go in order here. Fran?
Thank you. Picking up on Commissioner Pollack's admonition that we stay flexible enough to allow for innovation. I'm trying to figure out how this new wrinkle to the regs, the attention to surgical, to the ORs, how that would be implemented downstream. Okay, so let's take a market somewhere in the state of Maryland where a hospital decides to convert from a full-on hospital to an FMF. And in doing so decides, instead of operating, currently we have 5 ORs, but we don't want to give up our ORs. We're going to give up 2, and we are going to bring with our FMF a different unit, not just for emergency patients, but we're going to bring 3 ORs, include that into our new facility, which these regs will now address. So now, because it's an exemption from a CON, that would take place in this community. Now, let's say HSCRC says, okay, those are rate-regulated ORs, so a procedure in those ORs is going to cost a lot more than a comparable procedure in an ambulatory setting, right? So we have, I think it's up to HSCRC to decide what the rate would be. It sounds like you would expect that they're higher costs, this type of facility, so they probably have to recognize that. But it is entirely up to them what they decide about what rate to give the facility. Well, see, that gets to the heart of my question. Are we inadvertently setting up a situation in a particular market that we're giving the ORs to an existing hospital, and in so doing, possibly closing out the need for a lower cost, more efficient ambulatory operator to provide ambulatory OR services in that community? And so maybe my rationale is flawed here. If it's HSCRC can make that determination as far as rate, maybe HSCRC would say to the hospital, no, you don't get rates on these 3 ORs. We're only going to give you ambulatory rates. Is that envisioned as a possibility in these regs now?
And can you comment on HSCRC's views around the regulations and the flexibility that they wanted?
I believe that they wanted to have the flexibility. We did speak with them about making changes to these regulations and the specific wording of them, and they wanted to have the flexibility and felt that that was acceptable. So this would be on a case-by-case basis. The hospital would come to them in advance of coming here and say, we want 3 ORs with our petition for a CON exemption for FMF, and HSCRC would make a determination about the rate. About rates, right. I think we'd want to closely coordinate with them. We have talked to them about the importance of that, because we do want to make sure that we're looking carefully at the assumptions that are used to develop the justification for those operating rooms. Could HSCRC change their mind after the fact? So they said, we'll give you regulated ORs, and then 2 years down the road say, not anymore. I mean, maybe that's not a fair question. Maybe for this. No. Yeah. Okay. I'll take that. Okay.
Okay.
Yeah. All right. Okay. Thank you. Yeah. Sure.
That's a minute to fly.
Well, Ms. Flank, I associate myself with Commissioner Pollack's observations. I think you did a terrific job. I know that this was hard, it wasn't easy to do, and congratulate you on the hard work that you've done here. I have a comment, and then I have a few very specific questions. The comment I have is that I'm going to vote for this. Obviously, I've said I was going to vote for it, and I will. I'll just simply remind my fellow commissioners and others here who may have been involved in this debate for quite some time that when this issue first came before the commission, I raised the issue about whether or not we ought to have freestanding medical facilities that were not connected with a hospital system, that could compete directly with hospital systems to bring much needed competition into this state. We have 48 hospitals in the state of Maryland. However, we have 3 hospital systems that dominate almost 3/4 of the Maryland market. Very frankly, from the standpoint of pure economics, this is not a good situation. I don't see it changing. On page 6 of the regulation, you make the point that in Maryland, an FMF must be administratively part of an acute general hospital and be physically separated from the general hospital. My recollection is that this is a statutory requirement, correct?
Yes.
Right. So it's not something over which we have any control. Just want to make sure that I'm right about, the basics. There is something that struck me about reading this. By the way, this is a very good summary of the discussion about the nature of the controversy and the frame of reference in which this all takes place. You mentioned, for example, that independently operating emergency medical treatment organizations in Texas, for example, have freestanding medical facilities, and that's not a problem in Texas. It's a problem in Maryland. But then you have something else, which says that an independently owned freestanding emergency center cannot obtain Medicare or Medicaid facility payments. I guess my question is this: is that a Medicare statutory requirement, or is that a regulation of the CMS? Do you know?
I don't know if it's a regulation or if it's a federal law.
All right. Well, that's something we have to look into. On page 16, between page 16 and 27, we established the project review standards for a certificate of need. I've looked through it, and I will tell you once again, of course, we all have some experience with this, but that's an awful lot of paperwork. I mean, it's really a lot of paperwork. Is that basically as a result of the state health plan requirements or the statute that governs us? That amount of work? Certificate of need for this institution, a freestanding medical facility?
I would say
or is
that
this something that's different?
It's statute. I mean, there are basic criteria that are supposed to be part of this.
So these are all. This is all statutory.
Yes, I mean, I think that we've tried to be more specific in giving an applicant direction for what we expect to make it a little bit easier. And so maybe it looks like it's harder because we're describing more of our expectations. But
I see you're making it easier. Okay.
I think that's
now
our
I'm happy
goal.
to hear that. Let's move right along. Okay. The one other issue, and I think this was a statutory matter. It says within 10 working days after a public informational hearing, the converting hospital must provide a written summary of the hearing and all the written feedback, et cetera, et cetera, et cetera, to the governor.
Yes, that's in statute.
Yeah, that's in statute. I know. I don't know. Maybe you don't have to answer this question. I'll just simply ask it perhaps rhetorically. I don't know what the point of that is. I mean, okay, fine. He's not going to do anything. Right. Right?
I think it's just a matter of...
I know. It's just a matter of letting him know. Okay. All right. Thank you very much.
Sure.
Great. Thank you. Diane?
Hello. I just have a general question, and that is, actually, I'll start by saying that the flexibility and the ability to recognize that the market is changing and incentives are changing, and we really do want to see innovation in new models of care that are more efficient and effective. This is great, the revisions to allow for that innovation. After reviewing this, I sat back and thought, okay, so if the difference between a hospital that's converting to a freestanding medical facility that might feel it's appropriate to get an exemption from CON versus an entity that clearly does need to comply with the CON process, what is the relative burden? Is it just as process heavy for an organization to request an exemption as it is to apply for CON? Or do you see it, I mean, I realize it's a really broad question.
No, I mean, I would certainly hope not, because the idea of an exemption process is that it is an easier process. And I mean, the big difference is not having interested parties, because that can really slow things down and they can appeal the decision. And so that's a big difference, I would say.
Just after reading it, it made me sit back and ponder whether it's clearly simpler to apply for the exemption if one would potentially qualify for it.
There are a lot of steps that were written into statute and expectations in terms of exactly what would happen. And so then we, of course, had to include that and reference that. So I understand that, like, it was very prescribed in the statute. And so it might seem like, okay, there are a lot of expectations for the exemption process too. And I think there are compared to some of our other exemption processes, but I don't see it as something that we have control over in this situation.
Thank you. But lack of interested parties could take as much as 50% or more of the work out.
Yeah, absolutely. It's a valid point. A valid point. Thank you.
So, Commissioner Pollack, if I understand it right, the hospital cannot close. The hospital must be connected to this freestanding medical facility. Is that correct? Or could the hospital close and just establish itself as a freestanding medical clinic?
Yeah, mine.
Okay. Please.
So it does need to be connected to a hospital, but the idea is that it's shutting down, and so it may be part of a health system, like it shuts down, but it's part of a larger health system, and so one of those other hospitals in that health system is then the parent hospital. Like, it's definitely the hospital is going away,
okay,
getting replaced.
So now I'm going to put my consumer hat on. I wake up and I read the newspaper that my hospital's closing down, and I'm going to get a freestanding medical center. How would I feel? I might be confused. So my question is, what's in a name? This freestanding medical center is confusing. It's not urgent care, because in the report you say some urgent care centers are now evolving with more sophistication to maybe approximate or come close to these as freestanding. But I can tell you right now, if I heard my hospital is closing, I'm going to get urgent care instead, I would be maybe upset as a consumer. So is this name in statute? What is in this name?
The name.
Where did that come from? Is that national? Is that just in Maryland? What is it?
I think it's just in Maryland, that term freestanding medical facility. I think it is confusing because it's so general. You wonder what is it, but it is the term we're stuck with.
So really, we're stuck with it. So I'm trying to get to the truth in advertising so that the consumer would know what's happening in my community.
I think that some of the existing freestanding medical facilities, they go by emergency center. And so I think maybe the emphasis then is on emergency services, which is appropriate for the ones that exist. I think it will be up to the person establishing it to try to educate people and help them to understand it better, given that it's a little bit confusing with the term freestanding medical facility.
Why don't we help the consumer now? Why don't we come up with a better term that more approximates what it is?
Well, it is in statute. I don't think that we can come up with a new term without changing the law.
Thank you.
Sure.
Jerry?
Commissioner Thomas, I think the idea is to keep the consumer confused. I go back to my basic question. You know, FMF was designed to take care of overflow. Now it's replacing underutilized hospital, which is created essentially by GBR, if you think about it. That they want underutilization of hospitals. That's how the hospitals make money. They decrease their expenses because they can have a skeleton crew. That's how they make money in the GBR. It's a game. How close can you come to the historical data as to how much HSCRC gives you in your GBR money based on historical data? How close can you come to that without going too far under or too far over? They're just as bad. Right now we're in crisis because we had too many patients. And the hospital actually loses money on that because they have all these expenses. They're not getting GBR money for the expense. the cost of taking care of those patients, but they're laying out money for extra personnel, so they're losing money. So the thing is kind of psychotic here as far as replacing a hospital with a facility that's supposed to only have been taking care of overflow from ERs. And people seem to ignore the gorilla in the room as far as where are these outpatients, where are these inpatients going to go? That's my biggest concern. And I hate to say it, but it seems like a lot of this draft is written by a certain system in Maryland. I can see it speaking directly to a situation that we have right now, and it makes me a little uncomfortable.
Other questions or comments? Bob?
Yeah, I want to follow up on this. On page 13 of your document, you point out that in 1985, Maryland, by statute, established a limited service hospital licensure category for a limited hospital. And it could provide, according to this, unscheduled emergent and urgent care with staffing and equipment comparable to a hospital emergency room, et cetera. Were the limited service hospitals, were they connected to any existing hospital systems or institutions? They were when this was enacted, or was this a freestanding hospital?
I thought it was enacted in anticipation that this might be something that would be of interest to a hospital that wanted to partially shut down, but then no one ever actually made use of this, so we've never had a
There was no administrative connection between this institution and an existing hospital. Is that correct?
I think that's correct.
That is correct. So we actually did have limited service hospitals in statute.
It's still there.
Statute's still alive.
Yes.
Is it subject to rate regulation?
No.
It is not.
That's why.
Okay.
I think there was an interest in having rates, and so
Well, it says here the ability to be paid at rates that would allow sustainable operation. Sounds very reasonable to me. And this is still on the books. All right. Okay, this was a revelation. Thank you very much.
Ben?
So the legislation to establish a freestanding medical facility was the first recent foray the Commission made into CON simplification, which I think demonstrates the challenges of taking something like establishing a streamlined process to the legislature, and much of the structure that people have talked about was really put into place as a result of legislative concerns about due process, giving communities opportunities to comment, recognizing, as some commissioners have noted, that the loss of inpatient services was something that the community had opportunities to weigh in on. So this, what I would say, by exemption processes, the prolonged process was spelled out in the legislation. A couple points. The legislation was general and didn't necessarily contemplate all the scenarios that have evolved over the last year. And I think the commissions, as well as OHCQ, have somewhat worked hard to try to align what the statute said with what the evolving landscape has envisioned. I think we've heard much more interest in other types of outpatient services. A good example is intensive acute psych services, which I don't think was ever mentioned last session, as potentially something that would be positioned at a freestanding medical facility. So the regulations were pretty general and didn't necessarily contemplate exactly what it was going to be. So I think it's been taking us longer than we might have if we had a clear-cut set of scenarios to deal with when the law was passed. I think we're pretty close to where we think we need to be. There are some additional alignments on licensure, as Eileen mentioned, that need to be changed. There are some additional provisions in HSCRC regulation as it pertains to rate, to whether all services located in the same facility have to be rate regulated or not. That's the current framework for HSCRC regulation. It's all or none. That's going to have to be likely be changed. So I think we may have been a year premature in some ways in getting this passed, but we're positioned now to move forward. I think there is consensus among the commissions that we have a framework for going forward. We're giving HSCRC flexibility on a case-by-case basis, whereas I think last year the sense was that HSCRC would define flexibility overall. We will rate regulate this, we won't regulate that, but as a result of what's happening in communities, that's going to be individually specified. What I want to emphasize, what I have not heard from anyone, and this can change because is that most of the systems, most of the hospitals, it's all the system that's currently talking about this, is there's not a whole lot of interest in rate regulated OR services at this time. We can't predict absolutely that that's actually going to play out, because in the communities where many of these hospitals are going to convert, they're recognizing that it's not going to be sustainable from the standpoint of payers. They're not going to pay. But there are other types of services that might be needed and might be necessary for vulnerable certain populations. The behavioral health population might be one example where you need rate regulations to sustain it. What HSCRC has said is that we see these facilities as we wouldn't apply rates necessarily that would be similar to what would be at a full-service hospital, but I guess I would use the term a skinnier rate that would reflect cost to operate that service at a freestanding medical facility. So I think HSCRC is signaling to those that would convert that these are not going to be generous rates, but they may be necessary in some points. We've been consistently reminding systems that we too think that outpatient surgery is largely going to need to be competitive. It's largely going to have to be market-based as opposed to rate regulated. But we do envision in certain communities that way, in order to sustain that capability, they would need rate regulation. We chose the FMF model after initially thinking that freestanding medical, limited service hospitals were the appropriate way to go, partially because the FMF model had at least been tested in this more limited situation, emergency services, where it was established to deal with overcrowding. So regulations had been adopted. It had, to some extent, been established. OHCQ had a licensure framework that had actually been tested, and consequently, we pivoted away from limited service hospitals that has never existed other than in statute. It still exists, and it yet may see it today, but I think this provides a consistent framework for what I would call an ambulatory care setting, an ambulatory campus, dealing with a variety of a couple different scenarios. One, a startup freestanding medical facility on one end and a conversion on another, and it's likely to work under the same regulatory framework, which I think is desirable.
Thank you, Ben. Any final comments?
I think I know the answer to this. Ultimately, the way the regulation is structured out, either to get an exemption or to get the CON, is ultimately a public interest determination by us. right? So whether or not it's in the public interest, that's right out of the statute, isn't it?
Yes, that is for the exemption process. That's part of.
I ask because I don't actually like general public interest determinations. Sometimes people disagree wildly about what that means, but we don't have any choice. That's just the statute.
All right, let's move to a vote. All in favor of approving the regulations, say aye. 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 Any opposed? One opposed. Any abstention? Abstention noted. Mr. Thomas? Regulation is approved. We'll move to something less controversial, which is the legislative update by Erin. And question.
So the process from here forward is this goes out for full public comment, and then does it come back to commission, and what is the timeline?
Eileen, what's the timeline? That it'll come back 2 months or 1 month? 2 months, 3 months?
My recollection is that so there'll be a formal comment period, and based on the timing of getting it reviewed and getting it published in the Maryland Register, the formal comment period will be roughly April 1st through May 1st. And so then I think May would be the earliest that we could come back with final regulations.
Thank you.
Can we make sure that it's, because there are many communities who are deeply interested in this, that it goes out not only to the typical stakeholders that we share it with, but that it also, you know, somebody writes up a short something in plain language, gets it out on social media, gets it out to the newspapers. I mean, gets the information far and wide so that we can get a broad swath of the public aware of it and commenting on it. No comments is not a good sign. So however much we can get this out so that, frankly, the public can review it would be great.
Okay, we'll work on that.
Thank you.
Thanks. Erin?
Thank you, Mr. Chairman. So we are at day 37 of the 90-day General Assembly session. February 3rd was the Senate introduction deadline, so all bills introduced in the Senate after that have to go to the Senate Rules Committee. February 10th was the House introduction deadline, so all bills introduced in the House have to go to the House Rules Committee. March 6th is the final day to introduce bills without the suspension of the rules, and March 20th is crossover deadline. So before you have our legislative tracker, and this pretty much represents the universe of bills that probably will be introduced this session. That's not to say that something won't come up at, later, but this is pretty much it. Ben had already discussed our budget hearings, but I can answer any questions about that if you have any. So just for my presentation overview, I've roughly organized this into 3 broad categories. First is legislation related to the Maryland Patient Referral Law. Second is legislation related to health and regulatory reform in the state. And third is the Maryland Comprehensive Primary Care Model. So, Mr. Chairman, it's up to you how I do this. I can run through the whole presentation and have questions at the end, or I can stop after each bill and take questions.
Why don't you go through the whole presentation quickly, and then we can kind of take it from the top of questions.
Great. So the first bill we'll talk about is actually being heard in the Senate Finance Committee today. It's S. Bill 369. There is a House cross-file to this, HB 403. It's the Maryland Patient Referral Law, compensation arrangements under federally approved programs and models. HSCRC is leading the effort to pass this legislation. It's necessary for the Care Redesign Amendment. It builds off of MHCC's work and legislation that was introduced last year by stakeholders who were engaged in the work group that we put together during the 2015 interim. I'm told that it represents consensus among most of the stakeholders, including specialists, including radiologists, orthopedists, anesthesiologists, and the MPCAC, and MHA and the MIA. There still may be some concern among other stakeholders, which we should hear today after the bill hearing, and I can inform you of that after it is talked about today.
The legislation establishes an exemption from the Maryland Patient Referral Law for certain federally qualified compensation arrangements listed here, and it requires that that the organizations entering into these arrangements file certain information with the Maryland Insurance Administration, and the MIA makes a determination whether the arrangement constitutes the business of insurance and how that arrangement needs to be modified so that it does not constitute the business of insurance.
Actually, tell you what, why don't we have questions after each one? Otherwise, I think we will lose the train. So,
sure.
Yeah.
Okay, well, with that, I will pause for questions. Great, I explained it perfectly. Next. HB 1053 is the Integrated Community Oncology Reporting Program. This bill may look a lot like legislation many of you saw last year. It establishes an Integrated Community Oncology Pilot Program. It requires MHCC to be the convener of this program and establish an application process for the program. It also establishes a clinical advisory group. This is a little different than last year. It's similar to the clinical advisory group that we convened for our work with cardiac surgery and PCI, and it allows for up to 4 oncology sites, 2 which will be need to be solely owned by oncology group practices, and 2 that are jointly owned by oncology group practices and hospitals or hospital systems. It also requires MHCC to report the results to the governor and the General Assembly after the 5-year pilot program is over. There's also yearly reporting requirements that the sites have to send into MHCC so that there's ongoing monitoring of these programs. I'll pause again for questions.
I thought we asked previously if there were data to the extent to which these pilot programs exist, or these programs exist in other states.
So you did, and we're still trying to find some of that data from the sponsors of this bill. They're trying to get to us some of their studies that they have. So we don't have anything yet to share with you, but we're hoping to soon.
But they believe that these programs exist in other states.
Yeah.
Which is my understanding also.
Yep.
It's pretty common.
Yep. They're just looking to see if there are any sort of studies that can really answer the question that you're asking.
Yeah. Even prevalence data just shows how common it is.
Okay. So the next 2 bills are really study bills. SB 571 and HB 909, the Maryland Health Insurance Coverage Protection Act, creates the Maryland Health Insurance Coverage Protection Commission, and requires the commission to assess the impact of federal changes to the ACA, Medicaid, or Medicare. It also requires that the Department of Legislative Services staff this commission. So I believe the thought is that this commission wouldn't be a commission like ours. It would be a short-lived commission that would eventually make recommendations to the General Assembly should anything happen at the federal level. HB 736 creates a work group to recommend changes, similar, except it is housed in the Department of Health and Mental Hygiene, and the executive director of MHCC is listed as a member of this commission, along with this work group, along with some other stakeholders.
Question?
Does CLS have the staff to do this, or would they be hiring consultants and experts, to actually do the study?
No, they would do it. It's my general sense that these are placeholder bills. They were introduced in the beginning of session to things happening things move slow and then very quickly on the federal level. So I think the idea is to have these bills in the hopper and ready to go in case they need to sort of just get them passed really quickly at the end of the 90-day session.
Did you say things move quickly on the federal level?
I said slowly and then very quickly.
I mean, if something were to happen on the federal level to change the Affordable Care Act, the regs attached to them would take about 2 years to be promulgated.
Right. But
it would help us to understand what the real implications were and how to react to it.
Yeah,
It seems like an attempt to react before there's anything to react to.
Well, I think the idea and the idea from both of the sponsors of these bills is to have a process in place to begin the study and the conversation of how to react, because our healthcare system is so tied to the federal system at this point. Yeah.
Other questions?
All right. SB 1020, the Maryland Healthcare Regulatory Reform Act of 2017. So this legislation reorganizes MHCC and HSCRC into the Maryland Healthcare and Cost Review Commission. It establishes a new oversight framework similar to the Public Service Commission, and it requires the new commission to submit a proposal for streamlining the CON process by 2018.
No more context?
That's it.
So I'm reading here that this would require 5 full-time paid commissioners.
Yep.
Do we have any paid commissioners now? I'm just checking. No, I'm just making sure. So this emerged from the legislature, or is it a recommendation that came from the 2 commissions?
So, well, that's a tough question. So it was introduced by Senator Middleton, the chair of the Finance Committee. This last year, HSCRC and MHCC have both been going through their preliminary sunset evaluation, which we have every 10 years, by the Department of Legislative Services. And DLS, while they recommended that we not go through a full sunset evaluation, they did recommend that all 3 of the commissions, HSCRC, MHCC, and the Community Health Resources Commission, be looked at again in 2020 to see where our overlapping responsibilities and regulatory oversight, where there is overlapping regulatory oversight and responsibilities, and start having a discussion about whether the commissions should potentially be merged or realigned in some way. So this isn't completely out of the blue, although it is a little bit earlier than what the staff to the General Assembly was recommending.
Other questions?
I just have an observation that the chair of the commission shall be at least, the salary of the chair of the commission shall be at least $40,000 a year. The good news is they'd qualify for subsidies under the Affordable Care Act. Just making an observation.
Affordable Care Act will be gone by then.
So I think that's what happens when you model a bill after a statute that was written in the 1980s.
So one lighthearted one is that the Public Service commissioners are compensated considerably more than $35,000. At this point, we would recommend that the commission continue to look at this, and there may be some elements of this that may be valuable, particularly study of CON that could be inserted into our budget language that would be how prescriptive we might want to make that study would be something that commissioner input would be helpful on. But I think if such a reorganization is contemplated, some study material ought to be gathered first, would be my thought, rather than do the reorganization and then study what has to be changed. But thoughts from the commission would be welcome, I think.
I mean, the point I'd make about the third point about streamlined CON is that when the commission has tried to look at it just from a process standpoint alone and say what kind of work could we take out and make it streamlined for the participants involved, we've run into a lot of issues that are just in the statute and the regulations. So opening up this dialogue with the General Assembly about what it would take to streamline CON would be productive dialogue.
Unrelated question. Yeah. Thank you, Erin. I know this is a busy time of year for you. You haven't exactly been killing yourself writing position papers. I mean, it's like no position. No. Okay, I get that. But there are two bills that that relate to subjects that we talked about, for which the position has indicated no position. And the first one is this bill, Senate Bill 61, about a mandate for digital mammography, and the other one was for lymphedema, which in the House. So I guess my question is there an opportunity to write a letter of information? We have done some analysis of this question, is what I'm saying, recent, and to put that forth for the benefit of the committee that's hearing the bill.
Sure. I mean, we have provided the reports that we finished over the we had over the interim. We did provide those to the committees on those two bills, and I would be happy to put that into a new letter. Yeah.
We got it to the right committee hearing these bills, so we're just connecting the dots.
Yep. Yep.
Perhaps I'm reading more into your comment, friend, or Commissioner Phillips, than what you meant. But when I look at the last point on SB 1020, we've also talked about, many times touched on the need to streamline the CON process. And I don't know if we're going to weigh in on this piece of legislation, but is there separate discussion around the interest or the need to streamline the CON process?
Well, there's discussion here, and we have talked about that with some of the stakeholders in Annapolis, but most of the discussion in Annapolis is through this piece of legislation. So the way that we are approaching this, and the way that I am recommending we approach this, is watch this piece of legislation. Again, this is not again, but this is a reorganization at the of executive branch agencies. So ultimately, this bill just came out of rules yesterday, and if it does gain traction, we're going to have to coordinate with HSCRC, DHMH, and the governor's office on how to respond to this bill, this whole piece of legislation. Separating out from that, the study and a proposal for streamlining CON, that we, as Ben said, we've talked about potentially getting some budget bill narrative or budget language that would have us study CON. That might be, one avenue for making that happen.
And then Ben.
Yeah, just one comment on the CON process. One of the major impediments that we've had in the past to major reform in CON has been statutory, not related to the structure of this organization or that organization. And until we can sort of get past many of the issues, hospital CONs of a series of things, but home health CON, hospice CON, nursing home CON, until we can get past the constituents and the special interest groups who are clearly finding financial advantage in the current model, we're not going to get any. It doesn't matter how you reorganize this. It's sort of like buying a new putter when the reason that you're not playing golf well because you're slicing the ball into the woods. It's the wrong direction to fix the problem.
Okay.
So I think the logic behind getting this in the budget language is sort of following how bills become law, that we have worked on reforming, and we've had some ideas, and we've gotten some ideas from the Hospital Association, among others. But by putting this on a legislative agenda, like other things we've done, currently the Rural Health Work Group is a good example that the ideas of what reforms could be put in place will be brought forward by a legislatively endorsed work group. By putting this in legislative language, you sort of bring it up to a higher level of attention of report comes to the legislature, they have a sense of we're going to act on this, rather than a executive branch organization on its own authority, or a constituency or that constituency coming forward. I think it gives it a little higher level of credibility. No guarantee, and keep in mind what I said. Simplification last year meant the SMS conversion bill became quite elongated.
Okay. So lastly, I want to talk about the Maryland Comprehensive Primary Care Program, and the reason that you don't have a bill in front of you is because the bill has not been introduced yet. So the bill that has been drafted, worked on by staff here, staff at DHMH, is at the Department of Legislative Services in bill drafting right now, and we're hoping to have it by as soon as possible. So I don't want to give a time frame because I don't want to make myself a liar. So the Maryland Comprehensive Primary Care Program, CMMI encouraged Maryland to include a primary care model as part of the progression plan. So the Maryland Comprehensive Primary Care Program is that model, which is part of the progression plan for phase 2 of the new hospital model. It creates a the legislation will create a framework for the program. The meat and the guts of the program will really be decided through negotiations with CMMI. It establishes MHCC as the coordinating entity for the model, and it establishes an advisory council to advise the commission on design, recruitment, performance monitoring, and model enhancements. And again, the meat and the guts of the program is all conditional on CMMI approval. So I hope to have an actual bill to show you all as soon as possible, and this way we can really start the discussion on, what needs to, how the bill needs to be amended, where we really stand, and then we can hopefully get this moving as soon as possible, because like I said, we are almost halfway through the 90-day session, and so we really want to get this going as soon as we can.
Questions or comments?
Yeah. So, Aaron, we did have a call, a discussion commission-wide about the bill, a draft that we've seen earlier, and we had some general comments about amendments that would tweak it to allow for more flexibility and various other things. Do you know if that got into the bill drafting that's happening now, or are we going to have to go back and do that?
So this is sort of a good news, bad news answer. After we had that call, I can't remember because the dates are all kind of coming together, but this is going to be an a departmental bill. So it means that we have the backing of the administration. That was decided before we had our call. And so the language in the bill had been approved by the governor's office before we had our call. So to go back and add new language, even though I think that it would be accepted, would have meant restarting that process. So to my knowledge, and I haven't seen it since it went to DLS, that language is not in there, although I did have a discussion with the drafter generally that the commission would want to put some kind of language around this model, not precluding any other models, but we would likely have to have some amendments to really get the language to where I think this commission would want it. But I think that that's fine, because I know that this piece of legislation is going to go through the subcommittee process, likely would have to have a work group around it, and there will be amendments, so I don't think that getting that amended in will be a problem.
Very good.
That's all I have, unless anybody wants to revisit something.
Any other questions for Aaron? Supporting details?
Is there anything on? Great.
Thank you.
Thank you.
move to the Maryland Patient Safety Center Annual Report. Just to give some context, in July 2015, the Commission established an agreement redesignating Maryland Patient Center Incorporated as the Maryland Patient Safety Center. In addition to redesigning the company, the agreement required it to submit progress reports to MHCC and present the strategic plan annually for the upcoming fiscal year. And then Robert Imhoff, President and CEO of MPSC, will provide the center's progress and present the fiscal year 2018 program plan. And then before Mr. Imhoff begins, Tressa Lee will also provide some introductory remarks.
Thank you. In terms of background, the Maryland Patient Safety Center is designated by this commission as the Patient Safety Center for the state of Maryland. And the last designation, I believe, was in 2015 for 5 years. So that designation ends in 2019. And in June of last year, Robert and Bonnie came before you to give you an update on their activities. And during that time, you asked a number of questions, they responded to those questions, and now they're back again to provide a progress report. So I did bring copies of the questions and the answers if you're interested. They're available and I can give those to you. But otherwise, Robert, I'll turn it over to you, okay?
Thank you. It's a pleasure to be with you this afternoon and have the opportunity to present our progress and what we're looking at for fiscal 18. Just to give you a little bit of background, these are our board of directors. There are three new members since we were here last. Michael Yokelson, who is the Vice President of Medical Affairs with MedStar National Rehabilitation Network, Senator Catherine Klausmeyer, and Kelly Corby, who is the COO at Northwest Hospital. This is our list of our dues-paying members. We have two classifications of membership with the Patient Safety Center. There are 43. Actually, we just got another one today, so 44 members. These are the hospitals that actually pay dues every year and in return get certain benefits for that. You do not need to be a member of the a dues-paying member of the Maryland Patient Safety Center to participate in our programming. If you are not a member, you pay on an a la carte basis for conference registrations, training, that sort of thing. Our next classification is through our Mid-Atlantic Patient Safety Organization. As you may be aware, we are a federally listed PSO through AHRQ. That means we have certain activities that fall under those auspices. We conduct safe tables and report and receive adverse event data from certain hospitals. Those are our PSO activities. To participate in the PSO activities, you must be a member of the PSO. There's no cost to be a member of the PSO. All you need to do is execute certain documents, confidentiality agreements, and business associate agreements. We have 38 members in this classification. And you'll see some members of the dues-paying group that are members of the Patient Safety Organization, and then some that are members of the Patient Safety Organization that are not dues-paying members. So most, however, share memberships. Our strategic partners, NextPlane, which is our new vendor for adverse events. We'll get into that in a little bit. HQI, which is the Maryland QIO. Vermont, Oxford, and AIM participate with us on our maternal and infant collaboratives. HFAM, which is the long-term care association. MHEI, the hospital association. Obviously, MedChi, CRISP, Society to Improve Diagnosis is working with us on planning our Errors in Diagnosis initiative. The Surgical Association, the president of which is on our board, and then the Johns Hopkins School of Medicine Armstrong Institute, which collaborates with us on several programs. Highlights for fiscal 17 that we are just a little over 6 months through the fiscal year. We began marketing our Caring for the Caregiver program, which is a fee-for-service program that addresses the second victim phenomenon. We are marketing this within the state of Maryland and also out of the state. This is one of the cooperative programs that we're working on with Johns Hopkins. We contracted them to develop the program, and we have been marketing the program together. We've had interest from hospitals and organizations throughout the country. In fact, just had a teleconference with an organization in Poland who is interested in the program. So we have instituted this in 4 hospitals, 3 within the state of Maryland, and then 1 in South Carolina. As I mentioned, we have 43 dues-paying members and 37 PSO members, pardon me. We commenced our primary C-section initiative in July and also the neonatal abstinence syndrome. These are the 2 programs we work on with, or in cooperation with DHMH, their Department of Maternal and Infant Health. Our Clean Collaborative program, which addresses surface contamination, which is a progression from our hand hygiene initiative, includes 18 hospitals, 3 long-term care facilities, and 5 surgical centers. Our Sepsis Collaborative, which we are about to end with our 2nd cohort, will end in April of this year. The cohort 1, which was 10 hospitals, ended about 16 months ago, April of last year. And then this cohort is 11 hospitals. It's an 18-month duration, as I say, will end April of this year. And then we are also serving as a consultant to HQI on their long-term sepsis collaborative, which will also be something that we'll be looking at for fiscal 18 as a more involved partner. We will continue with our education and training into fiscal 18. We offer a number of different programs at different times and different years, including things like root cause analysis, failure mode effect analysis, Six Sigma, lean training, team steps. We have some new programs that we'll be offering this year around appreciative inquiry, and we're also offering a kind of patient safety 101 course that we call Foundations in Patient Safety. We will also be continuing with our 2 conferences. We have a conference in late fall, early winter around medication safety. Last year's topic was the opioid situation. We also have our annual spring conference, which attracts about 1,200 to 1,500 attendees each year. So I'm going to turn things over to Bonnie, who will discuss with you the data and the graphs for our ongoing initiatives.
So let me just preface this to say we have lots of data and lots of graphs, and so for a presentation like this, I'm always, trying to narrow down, not to overburden you, but to give you something of interest. Last year when we were here, I reported on cohort 1. You'll remember, maybe some of you, that this is self-reported data, self-reported mortality rates, but at the same time we're tracking the state rate, because our overall goal was to decrease sepsis mortality in the state. You'll remember that this particular collaborative is a little bit different than any that we've ever done before, in that we didn't prescribe process measures or say to hospitals, you must do this particular order set. We only are looking at outcome measures, and they're self-reported of what their mortality rates were for 2 ICD-910s, and that's severe sepsis and septic shock. So we're just looking at those. So what I pulled for you is the graph. Cohort 1 dropped their sepsis mortality rate by 19% over the time of the collaborative, and these are cohort 2, which is actually 11 hospitals. We also limited the number of participants in this particular collaborative because we also have some consultants in human factors that are working with each individual hospital team, and the saturation point for them was 10 teams that they could work for. So that was an interesting phenomenon, just because when we limited who could participate, we were overwhelmed with tons of people wanting to participate. So the top graph is what we've got going on with cohort 2 right now, and then this data, sepsis mortality for all the Maryland hospitals, comes from HSCRC, so we just track with it. Yes?
I see it sort of benchmarking to ourselves over time here, but within this model. But are there national benchmarks? that we can use to
I
understand
was just
what
asked
means?
that yesterday, like how do we in Maryland compare to other states, and I haven't had time to pull that, but I bet there are. We just haven't been doing that, but I could get them for you. Okay. If they exist. One of our subject matter experts on this this project is a Dr. Philip Dellinger, who's been one of the founders of the Surviving Sepsis Campaign, which is an international and national campaign, and I believe he probably has data for me. Yeah.
Could you just explain the y-axis on 1 and 2? What percent was?
What percent of what?
Yeah,
so we pulled the number of cases that had a particular, there's two ICD-10 codes. So all cases with that versus how many of those died.
In the participating hospital.
In the participating, and well, the bottom is all hospitals in Maryland.
The bottom, Bonnie's referring to this next slide.
Oh, I'm sorry.
So the participating hospital mortality rate is higher than than all hospitals. So it looks like that's
Well, which figure are you looking at?
I just grabbed the first one. Maybe that's not true with
So the cohort started a little lower, about 2% lower than the state. Is that what you're saying?
Yeah, the x-axis is there.
Oh, yes. The cohort started,
Yeah, the cohort started at 26.45, and the state, the state started, this is going back further. Cohort, let me find 50.
I can see what I'm trying to, it doesn't look like there's much of an effect of participating among the hospitals that are participating that are graphed on the first graph. Don't have much of it.
Compared to the other hospitals in the state. Yeah, well, I mean, we're seeing an almost parallel thing here, but all of the work that we're doing is also being shared. Like, we're pushing it out to anybody, every patient safety officer in the state as well.
So if everybody improves, you might not see a difference.
Between the cohort and the state,
no.
Correct.
Are you able to determine the source of the infection that led to the sepsis?
We haven't asked for that data.
But that data is known. So you'd be able to tell me that what proportion came from oral infections, for example.
I wouldn't be able to tell you that.
But your partners providing this data could, yeah?
If they're collecting that in their case reviews, they're reviewing the participating hospitals are reviewing the cases, and there's a CMS core measure on sepsis, so they're pulling a bunch of process measures. What happened with cohort 2 is right within months after us starting this, a CMS core measure went into effect as well. So we've been seeing that effect of the decrease in the state sepsis rate totally impacted by that CMS core measure too. So, but back to your question about what's the source of the infection, I don't know if anybody's collecting that. Yeah, they could. Yeah, but
good.
Yeah.
I'm curious of the source.
Oh, okay. Yeah. Okay. Next. So the other collaborative that we're working on is called the Clean Collaborative. And this particular collaborative came sort of out of, we did hand hygiene for 4 years. And this collaborative is looking at surface contamination in the patient care areas in the hospitals. And then we added 8 points of public areas like elevator buttons and armchairs in a waiting room and things like that. The metric that we're using a technology called ATP technology, and it looks at, provides a quantitative number of something called relative light units. So many of the hospitals, and not as many of the other facilities, but many of the hospitals are using like a glow stick to evaluate the effectiveness of how well a housekeeper cleans. And it's a yes or no. It's a color change or not. But we wanted something more quantitative. So there is this ATT technology that provides a number. And the relative light units are it's scientific. It's like an amino acid left on a surface. And that's an indicator of contamination. Our goal was to decrease the overall RLUs in the facilities. We used 17 points in the patient care rooms that CDC identified as high touch areas, like the overbed table, the call buttons, the handrails, those things. There's 17 of those. And then we selected 8 public areas, random public areas, knowing full well that a housekeeper could clean an elevator button, and as soon as you or I touched it, it's going to have contaminants on it. So we're not trying to get a sterile environment or a super clean environment in those areas, but we wanted our facilities to be able to look at maybe they need to increase the frequency with which those areas are cleaned. So we've seen a decrease, but the ultimate outcome for this particular initiative is to decrease facility-acquired infections. And we've been able to get some data from the Maryland Hospital Association from a database for the hospitals where they're tracking CAUTIs and CLABSIs. We were interested in C. diff and MRSA, and we were interested in VRE as well, but they are not collecting that. So what you see is the top number is those in the collaborative. The bottom in both graphs is not in the collaborative. And so, yeah?
They're not seeing the bottom.
Oh. Thank you. Sorry. So what we were upset about, or a little bit upset about, was like, well, if you're doing worse if you're in the collaborative. So in talking to our members, we're like, what do you think's going on? Especially in the hospitals, they were saying to us, we knew we had a problem, that's why we're in this collaborative. So we'll continue to monitor that. This collaborative was a 1-year collaborative. I mean, the good news is everybody's coming down. And we don't have long-term care or the ambulatory surgery center numbers because they're not required to report it into a particular database. So talking to them, they do have to track internally their numbers, they told me, and they're willing to share those with us. So more will be coming on that as we get further into this. Okay. Yes.
For some of this stuff, it's very difficult to really understand or make heads or tails of. So what's the difference between a standardized infection ratio of 0.91 and 0.95? To what degree is that statistically even close to relevant? And you've got just 3 quarters listed here. So it's very difficult for us to understand Q3 over Q3. In other words, year over year in this model, because Q3 may not look like Q2 because of weather differences in terms of infection patterns and infection rates.
Exactly. And these particular standard infection ratios have a definition that I'm not 100%. I get these numbers from MHA, which comes from a national database, so I can get you those and send you those, but I don't have a whole lot of data points. I'd love to know how we looked last year as well. So I can get you more information, but I don't know it
and we're only
right
looking
now.
at 7 months of collaborative.
Okay.
And yes, thank you. Yes. Okay, the C-section collaborative we began recruitment in April, May, and June of last year. We had an information session. This collaborative is in partnership with an organization called AIM, or the Alliance for Innovation in Maternal Health. And what AIM is a coalition of professional organizations devoted to improving maternal health, like the American College of Obstetricians and Gynecologists, like AWAN, which is the Nursing Association, the Nurse Midwife Association. It's about 5 or 6 of these organizations came together and developed a set of recommendations, or what they call a bundle, for a number of patient safety issues. I think the first one they did was on obstetrical hemorrhage. They've done one on hypertension during pregnancy. They've done one on DVTs, and they've done one on reducing primary C-sections. I think last year we talked about why we were going to look at this, but you may recall that if a woman has a first C-section, subsequent pregnancies, there's a 90% chance that they will be C-sections as well. So Maryland has a very high C-section rate, 7th highest in the nation. And the thought is if we can impact the primary C-section rate, we'll be able to impact our overall C-section rate. So we recruited 31 of the 32 birthing hospitals in Maryland into this collaborative, so that's a pretty high recruitment rate. And we are the only state in the AIM project that is looking at primary C-section. Trinity Health, however, which is a large health system nationally, has just joined also and is looking at primary C-section. So we've already partnered with them to share some of our work. We're about 8-9 months ahead of them. So what I only have 2 data points for you so far. We're working with DHMH to get state data. Vital Statistics agreed to provide us with primary C-section rates 1 quarter behind, so it's not final data. So that 2016 data that you see there in the second chart isn't final state data, but we got an agreement that they would give us data, preliminary data, so that we could work on some rapid cycle improvement. So what this graph shows you, it's a caterpillar graph of all the participating hospitals. They're color-coded by number of deliveries. So since we're a small state, you probably, if you studied it hard enough, might be able to figure out who everybody is. At least they can, because they're familiar with each other. But we're not sharing each hospital's data with the other hospitals, but we also, we're not, if they share it, it's up to them, and they're a very sharey group with each other. So the first graph shows you, I entered the goal line for the Healthy People 2020 goal of overall C-sections, which is 23.9. Maryland's state rate was 33% when we started this. So what's of interest is seeing the number of hospitals that are at or near that goal line a year ago versus the additional ones that are at or near it now. And I only have 2 quarters, or that's the second quarter once we got started, and we hadn't even worked very much. It was just an awareness, and sometimes just telling people that you're looking at things changes behavior. And I believe that's what's happened here, because we hadn't really gotten full in education and webinars and strategies to improve and work on with the team. So we're looking forward to some really good results with this particular collaborative. Yeah.
So, funny things happen when you disentangle the numbers by certain demographics. So I'm just asking, is it possible? So is it possible to disentangle this graph by, for example, race, ethnicity?
It is. I do have that data. So we did ask for the state data about this to do some, so we'll have some disparity graphs in the future, but we can. The state is providing them.
So for our purposes, I think it's important to be able to see if the progress is being made, is it being made by everybody? And that's one variable. Another variable may be source of insurance, et cetera, et cetera. So I think it's important for us to see what's underneath these numbers, as long as the data is available.
Okay. All right. Neonatal abstinence syndrome is our other initiative, and this began in October. Neonatal abstinence syndrome is babies that are born exposed, drug exposed, and are going through withdrawal after delivery. What we found in Maryland, in our Maryland hospitals, we did a survey of practices and things before we ever started. And the issue was that there were just so many inconsistencies in treatment within the hospital walls. So pediatrician to pediatrician were not necessarily consistent in their treatment of the infants. So our goal was to standardize treatment within the hospitals. There are a number of ideas about how to best treat, and there are a number of protocols about whether you treat the baby based on their signs that they're displaying or based on weight. There are evaluation scores, which also are fraught with subjectivity. So we're working to try to make sure that the nurses that are evaluating signs for these babies are consistent or close to good inter-rater reliability, and asking hospitals to adopt a standardized practice within the hospital. 31 of the 32 Maryland birthing hospitals are participating in this. It's not the same one that's not participating in the C-section one. And we also have Mount Washington Pediatric Hospital is participating in this because many of these babies go to get referred there. Just to give you the baseline data, I don't have any comparative data yet. Our baseline months were January, February, and March of 2016. We did chart audits. We're looking at the number of medically treated NAS cases in the 31 hospitals. We had 139. 22.3% were transferred either out to a higher level of care or to Mount Washington. Median NICU stay was 11 days, which is very costly. And the median hospital stay, which included time of birth to discharge from wherever else they went. So we took the whole length of stay that included Mount Washington, was 19 days. We're also looking to see if we can get some readmission data. Sometimes these infants are not identified at delivery, and then they start suffering from symptoms, signs of withdrawal at home and have to come back. So we're working with HSCRC to get data on that. Yes.
So do you think that a hospital has a role in post-discharge for an infant who is born addicted to opioids or heroin and suffers neonatal abstinence syndrome beyond the acute clinical treatment that you described?
Yeah.
You know how these babies get in the situation that they're in, and then to discharge them back home is something of a worry.
Well, they're always referred. I've learned a lot about this working with these hospitals on this project. And they're always referred to case management and or social worker, depending on the resources available, and there is evaluation. Many of them come in with a mother that's in treatment. What I've learned is that during pregnancy, there's a high motivation in women. They think it's intrinsic to come off. So rehabilitation, that's a great time to rehab a woman because, and we had a young lady speak at our kickoff, and she said, I didn't care about myself enough, but I love the baby more. So she got into treatment. So often they're in treatment and either on methadone or buprenorphine, and the baby's born addicted to that. So working with them, evaluating the home situation, it's a whole continuum. There's a whole lot on the front end also that we've been questioning. This particular collaborative is focused on care of the baby in the hospital. But in our bundle and sort of list of recommendations was, wouldn't it be nice to screen these people before they ever get to the labor and delivery unit, to know before then, and to do what role does the hospital have in intervening before? But in answer to your question, I think the complexity of the care of these women is huge. I just Maryland just got a SAMHSA grant, and I'm on that team, and they're looking at improving the care of women dependent on opioids and their babies. And it's like world peace, you know, it's so big, and where we can intervene at different places there's a lot to do. But, and then there's resources, you know, does the hospital have a resource? But they do evaluate, I can assure you that.
And you have rural hospitals in this data set?
Yeah, I don't know where that question came from.
Right over here.
Oh, thank you. I'm deaf on this side,
That's
so
okay.
I can't ever find it. My stereo's gone. Yeah, it's 31 of Maryland's 32 birthing hospitals are in this. So Garrett and Carroll and, you know, all of them are in this collaborative. Yeah. Okay. So Robert's going to talk about our adverse event reporting.
The next has been, I know, a topic of great interest to the Commission, and I'm pleased to report that we have had a great deal of success. As I mentioned to you in our previous update, that we had difficulty finding a vendor that we could use to distill information from all the different hospitals dealing with different vendors. We seem to have accomplished that. We found a company out of Texas, NextPlane, that deals with lots of different PSOs. Remind me again.
I think it's 11.
11 PSOs, and they're dealing with data from over 600 hospitals. So we have employed them. We started with this year has been a bit of a beta test. We have license for 12 hospitals. Right now we have 6 recruited. We're continuing to recruit for the additional 6. As far as testing and seeing how it works on both ends, both receiving the data and entering the data from the hospitals. So far the reports have been very positive. We were very concerned about the hospitals having to enter the data and it being mapped properly. We're getting no negative reports from the hospitals in this regard, so we're pleased there. As you see, there have been over 10,000 adverse events reported as of 2/19, and this goes back to the date of the PSO contract when those hospitals became members of the Mid-Atlantic PSO. The largest category that we're seeing right now are medication events. Again, this is a short term with a limited number of hospitals. To be significantly significant, we're going to have to be in the low 50s, high 40s, low 50s to be getting data that we can really start trending with. The plan next year is to increase the number of licenses and up recruiting and get more hospitals. We're also looking at seeing if we can't do something on a more regional basis. As we get this data and as we develop these trends, we will post that on our website. The data that we post will be de-identified aggregate data. This information is part of, as I mentioned before, is part of the Patient Safety Organization and has certain protections, so it needs to remain confidential and anonymous. Questions on that? As I know that was a topic of great interest last time.
Diane.
Just a quick question. I mean, de-identified aggregate data is kind of useless in terms of reporting it publicly.
Well, it shows trends.
Okay. If it's compared to national benchmarks, you know, that's helpful. And it's interesting at a policy level, but in terms of really informing the public about how common is it in a given hospital, and I'm not saying naming the hospital, but simply, you know, blind the information that the charts, the Caterpillar charts that you showed, that's very helpful because at least you get an idea of, you know, where the average is, but also what's the range of variation among hospitals in Maryland. Anyway, my question is, to what degree is you said the de-identified aggregate data is required for the adverse event reporting because of the PSO requirement?
Correct.
Given the other activities of the Patient Safety Center or Patient Safety, the whole Patient Safety Center, not just the PSO activities, what do you work on that isn't restricted? in terms of being able to be more transparent about the findings?
The only two things that we are exclusively or definitively restrictive on are our safe tables, which are discussions around specific issues. There are no notes taken, there's no reporting out, and it's strictly an open discussion. And the adverse event reporting. Both have the federal protections allowed to us because of being a federal PSO, which is the attraction for hospitals to openly report. That was the whole idea behind the protections and the 205 PSQI, Patient Safety Quality Improvement Act. So that's their incentive to report as much information as freely as possible.
So, okay, so the protection of the black box, I get it for the adverse event reporting. Flipping that around, that means the other work that you're doing, there is the ability to be more transparent.
There is, and getting hospitals to agree to participate, is and to report their results or even share their results amongst each other has been has to be a gradual process. The Sepsis Collaborative is the only one that I'm working on right now where the people in the cohort can see the other hospitals' data. And that was in part of the recruitment. We said we're all about transparency in Maryland, so we're inside the group. So it's a start. Hospitals seeing each other's data is a whole new thing, and the whole transparency and working together to improve the care in the state is new for hospitals. And, so it's like our first dip in the, toe in the water. The AIM portal and the neonatal abstinence data, it's not set, they're not our portals. We partnered with Vermont Oxford and with AIM. So the data's going into their portal, and the way they built it was that hospitals can't see each other. But we talk on the calls all the time because you want the hospitals that are doing well to partner with those that are struggling. So even though I don't say what your rate is, I say, so-and-so you need to call these people over here, and I connect them. So I think that we're in the beginning phases of this transparency, but I don't think that if we I wasn't sure if anybody would sign up for sepsis with that criteria that you're going to see each other. So we have not posted, and it's self-reported. So there's a limitation right there to, self-reported preliminary data, because I'm asking for data a month after, and the coding isn't even final. So it's preliminary self-reported data even.
I want to thank you for the presentation.
Thank you.
Very,
You're
very
welcome.
good. As a commission, we have statewide responsibilities. And as you probably have picked up, appearing here, transparency on quality and performance is very, very big. I think it's fair to say with every member of this commission. In order for us to do our job and to do it well, we have to have very sound benchmarks to show how Maryland is performing. Now, in the data that you presented today on sepsis, on neonatal safety, and so on, do you have national benchmarks that are applicable to the material that you presented to us today? In other words, is there some way for us, in the job that we do, to be able to say how Maryland is doing compared to the rest of the country in the areas that you have outlined for us today?
I have
you
it
have that
for
data.
C-section. I can tell you NCSV C-section rates by state.
Right.
I have neonatal abstinence syndrome. We're looking at length of stay and transfers to higher levels of care. But the other metric that is important to us, but it's so much bigger, is the number of cases in Maryland, which I can tell you totally parallels the number of overdoses in Maryland. So I can get you some of that. The sepsis, I believe it exists, but I don't want to promise it to you. I just haven't asked for it.
I know you can't promise it to us now, but if you have it, I think
I will give it
every
to you.
member of the commission would want
Sure.
that data.
Okay.
I want to ask
send it to you, and you could distribute.
one other matter. On C-sections, you said we're the 7th highest in the nation. Okay, and I understand the argument about too many C-sections. We all understand that. What I am interested, though, is the other side of that issue.
The legal side?
Well, the fact is that in a number of cases where you should have had C-sections, you don't. And there are consequences to that. From the standpoint of patient safety, I think of two things. One is preventable cases of cerebral palsy and Erb's palsy in particular. Just two examples of this. Do you have any data on that, or you plan to collect any data on that kind?
We have no plans to collect that data. I could probably get my hands on it. I mean, one of the concerns the obstetricians and midwives had with this particular collaborative was also we are one of the most litigious states in the nation.
Right.
So they do practice defensive medicine when it comes to delivering babies. So this particular collaborative, we're not saying don't do C-sections.
I understand that.
You know, and I was at a meeting with Dr. Burke, who's our medical co-chair on this, and she explained that we were meeting with a new OB chair at one of the hospitals about this work, and she said the answer is practice good medicine. Do what's right for the patient at all times.
Yes.
And sometimes there are other reasons to be doing the C-section, and we're finding it's 11 o'clock in a rural area with the one obstetrician on a Friday night, and mom's been laboring 8 hours, and everybody wants to go home.
I understand.
So there's those.
And we saw the same thing with early elective delivery.
Yeah. So,
all I'm saying is that in terms of us being able to do our job as a commission, we need that benchmark information.
Okay.
And it's not just the number of C-sections, but I think from the standpoint of patient safety, it's bad medical outcomes, such as preventable, if that's going to be hard. But what you can do in terms of saying cases where there are bad medical outcomes for neonatal cases, like Erb's palsy and cerebral palsy, we'd like to know that.
Yeah. Compared nationally.
Yeah.
You know.
Yeah.
I also think it's important to point out that with sepsis, there are measures that are coming out, there are new measures that will be able to do just that. And what they're doing here, hopefully, will help to increase awareness within the hospitals in terms of how to address sepsis.
Yeah.
So even if you can't publish report this, we're hoping that that will have some positive impact upon what we're doing with reporting sepsis.
Right, but my point is the hospitals, there's the hospital world, and then there's the world of public policy, and that's the world we exist in. And we have a responsibility to the taxpayers to do the best we can to making this kind of information available on a general basis. That is our job, and so that's why I'm interested in the national benchmark. Thank you.
Yeah, and just to build on Bob's comments, I was going to wait to the end on the strategic direction, but I'll just see if he's opened the door. I'll continue to go through that. Just for the commission, we need to have one member of the commission, join the patient safety board. Bob Fronston had been on there before. There's a seat, and so looking for volunteers. I'm seeing some volunteers, so that's great. So that's the first thing. The second thing is, even though we're not on the board, we are supposed to comment on the strategic direction. The patient safety board has been commissioned by MHCC for at least 7 years or so. And so, I mean, let me just make a comment or two around the strategic direction. I mean, I think that strategies should be clear, aspirational, and with, and in the right direction. And I think that here, the comments that Bob is starting to have is, I think, a dialogue that Trust is very familiar with, because we have it a fair amount as we're looking through the outcomes, which is, really to understand what is, the art of the possible here. And so, so I think it's really around clarity around what can be achieved. And So it may be the national benchmarks. I mean, I happen to know the sepsis data, and that in Northern California, UCSF got it from 28% down to 16% over a 2-year period. You know, those are, even though it's not a state specific, it's kind of like, okay, well, there's, 16%, low, double digits is what can be possible. I think that would make everybody's eyes pop here and say, oh, well, that's interesting. Now, what can be done? And I know that actually putting together a board where you have volunteers, sometimes you're in the consensus period, which may sort of dilute some of what you need to do. But I guess I do wonder, is there the aspiration to get Maryland into the top decile or top quintile in terms of safety, as a state, or is there anything? I haven't seen that, and so I just do wonder. I mean, I know that as we've talked about the data here, when it comes to quality, I think there's always a reaction from the commission about not holding ourselves to our specific standards, but either a national or even if there's an absolute case, then that's the case. And I know these things are hard to do. I mean, just from an interest standpoint, 30 years ago, I looked at the C-section rate for Maryland and 10 months as an analyst and all that data, and it looks pretty much unchanged over a 30-year period. So a lot of movement of these things are not straightforward. But I'm just curious about. I'd love to hear a little bit about the challenges you might face in kind of getting clarity of direction, because I see a lot of initiatives, but it's not, in terms of clarity of what
there is method to our madness. And we actually are in the midst of reworking the organizational mission statement. Our mission statement now, I did not present it again this go around, but I did last, is to make, it's a very lofty mission, is to make healthcare in Maryland the safest in the nation. Now, a question about within our board structure has been, what does that mean? What measures are we going to look at on a national basis, and then what initiatives? And that's a question that we've not answered yet. But it is a question that the board is struggling with and working on. We've been talking about that for several months, because it's a very ambiguous statement. Safe in what regard? Are we is our sepsis rate the lowest? Or healthcare-acquired infections? What does that mean? And we're at that point in the organizational maturity that we need to review that and provide some clarity to that. So that is not something that we aren't considering, and that is not falling on deaf ears. So, and as we go forward, and we'll talk about our initiatives, what we're proposing for fiscal 18. We have criteria that it crosses the continuum, the provider continuum. It's just not hospital focused. That there's a consumer impact to this. That we are looking at things that we can do from both a human resource standpoint, financial resource standpoint, where we can have impact, and things within the priority. And we talked to many different groups about that. Yes, we're trying to make Maryland safe as possible. We unfortunately have to pick and choose and be very specific about what we do, because resource allocation and what our limits are. We're a 5 FTE shop that contracts out a lot of things, and unfortunately our budget doesn't increase every year. And I don't mean to cry foul or poor, but it's just kind of statement of fact and what we deal with on an annual basis.
So I can only imagine how difficult it is to get these systems to trust one another and to build. So that in and of itself is extremely important. So that's number one. Number two, I wonder the extent to which, there's a whole body of literature here as well. And so I'm thinking of our doctoral students, for example. If you currently do not have fellows and interns from the university that could in many ways add value with oversight from faculty, who could do those things that can extend and also contribute to their education and contribute to the broader dissemination. Because to get those systems to work together is the hardest part. Now that you have it, the data extraction and the kind of analysis that can be done actually could contribute significantly to the body of literature out there. And I think so that interns, fellowships from our universities could add value in helping to drive
what that next step might be. You know, they could consume that literature and feed that back. That might have implications for what are the next kind of data points you monitor. So do you currently have interns and fellows? We do not, but we, however, are looking at that. We are talking to Bloomberg School of Public Health. That's one school around that very thing. And we're also... You haven't... There's a school that's actually part of the state of Maryland. You didn't let me finish. And we are talking to UMBC. That's two. Yeah. So... there's a third one. So, just tell me which one you want. University of Maryland School of Public Health, College Park. And the University of Maryland School. I'll help you. Yes, we are looking at that. We are, again, limited by these. There are financial costs involved with that. So ours come free. Well, then I will definitely have a conversation with you then. So thank you. But we are looking at research papers. We met with UMBC faculty recently, and I've met with faculty at the Bloomberg School about interns coming and analyzing and helping publish things. So, yes, we are looking at that. Thank you for the suggestion, and I will be in contact.
You mentioned that these statistics here are voluntary contributions by the hospital. It's safe to say that the actual rates of mortality from sepsis is higher, and how reliable are voluntary statistics?
I don't have a figure on how reliable they are, but it has been found effective for collaborative work, for rapid cycle improvement, for them to be looking at their own. Now, you know, is it something that, you know, this is your hospital's rate? And it's pre-final coding that we're asking them for. So, you know, there was a little bit of angst in the beginning when we began, because they were like, well, it's not the final rate. You know, where are you going to, is this being reported? And I'm like, no, this is a collaborative. So sort of this, you know, there's no advantage to them by anybody to lower their rate. You know, they should report what they see. So they're not, you know, it's for their own improvement and their own gain. Their sepsis rates are being fed back to them anyway in finalized form by other entities. So for collaborative work, it's about, you know, it's like weighing yourself when you're trying to lose weight. You know, it doesn't benefit anybody if you say, well, yeah, I lost 10 pounds, and you didn't.
So moving on, these are the initiatives that we're looking at for fiscal 18, continuing the perinatal neonatal quality collaborative with both the C-section and the neonatal abstinence syndrome. We're talking to both HSCRC and HQI about a sepsis collaborative. We're very interested in participating. We're taking the work we've done in the acute care setting and moving into the long-term post-acute setting and seeing what impact we can have there. So we're talking to HQI about an initiative, the CLEAN Collaborative. We would like to continue into the emergency departments. There's been a great deal of interest with the participants in that regard. Errors in diagnosis, we actually conducted 3 study groups. Errors in diagnosis, which was because of the impetus for that was the IOM report a couple of years ago, talking about the problems with diagnosis. They made 8 recommendations. We're talking to, again, the Society Improved Diagnosis in Medicine, which is a national organization, and we're talking to a neurologist at Hopkins who's developed some algorithms around stroke and heart attack diagnosis. So a 3-phase program that we're looking at identifying the scope and then developing plan of actions and then implementation of that plan of action. Opioid misuse is a big state priority and certainly a big patient safety issue. So we're looking at, and I could talk our allotted time on this one issue. We are looking at a proactive approach around consumer patient education and also a physician education component. And then we're also looking at, we're mirroring a program that came out of Massachusetts in cooperation with their state medical society. Are you familiar? You're nodding your head. It's been a great deal of interest for us. where the medical schools in Massachusetts got together and developed curriculum around opioid prescription. Medication reconciliation is another study group we convened. We're looking at three components there. Patient education, we're looking at education with clinicians in taking proper, asking proper questions to have a complete medication reconciliation, and then working with CRISP and the data that they have to develop initiative around that. And then, as I mentioned, adverse event reporting will continue in a more robust manner as we recruit more hospitals and get more data input into the system. Questions around what we are looking at for fiscal 18. We tried to do as many multi-year programs as possible. 12 months is a limited time to have impact, so we're really trending toward multi-year activities. Ben?
So your adverse event reporting, you said you had a contract for 12 hospitals that had only gotten 6 to sign up. What's the plan for getting those additional 6 more?
Well, it's a little bit of a process with the hospitals for them to sign this documentation. It goes through legal and it's back and forth, and there isn't. I don't want to say the hospitals are, pardon the pun, averse to doing this. But we found that there is a real process to go through to get them to agree to do this. We're talking to the University of Maryland about a system reporting situation. It's a little bit of chicken and the egg. We only have 12 licenses. If you have a hospital or a system with 14 hospitals, they're essentially reporting their own data and trending there. So the more hospitals we get, the more incentive there is for larger systems and multiple hospitals to become involved. So it really becomes a perseverance issue, and we just have to keep pushing, and as we do with all our recruitment. We have no authority to require anybody to do anything, so it's voluntary, and we try to make it as easy and as beneficial for them to do, not only for adverse event reporting, but for all of the initiatives.
Thank you.
Yes, ma'am.
Commissioner Thomas, thank you. I'm just thinking back to, all the reasons why a hospital would be reluctant to engage in the adverse event reporting. When you have morbidity, mortality conferences, other sorts of things, they're specifically protected from discovery in malpractice actions. Do you have a similar type of protection in effect here?
As a federal PSO, we have federal protections, which is the incentive for the hospitals to report this data. Without that, I doubt we would have anyone reporting.
Okay. But even with this, there's a reluctance. Mm-hmm. Well, you're used to it being in-house. Yeah. Mm-hmm. Okay, thank you.
And just very briefly, when I look at the list, the one thing, thinking of the state of Maryland, it's one of the most diverse states in the nation. And so the absence of an explicit examination of health disparities or health equity, the point being that in each one of these areas, rather than, my follow-up question, can you break this out by a health disparity framework or health equity framework says we're going to look at those dynamics up front. We're going to look at socioeconomic status and how the data runs. We're going to look at racial ethnic diversity and how the data runs. We're going to look at immigrant, non-immigrant, rural, urban. So that's not an afterthought, because in the aggregate, it is not as informative. Because some of your hospital systems may have a greater burden in terms of certain patient populations that affect how they look to their comparison group. So I would encourage you to think about how you can incorporate health equity, health disparity as a lens through which could be a common thread across all these different dimensions here.
Absolutely, and this has been a big part of the discussion around the opioid misuse initiative, the racial disparities and the ethnic disparities and geographic and all that sort of thing. So yes, it is on our mind. Thank you for the suggestion. Thank you very much.
Okay. Wait,
Oh, one
is
more?
there one more
Oh, I'm
slide?
sorry.
You were
I'm
waiting
sorry.
for the last
Excuse
slide.
me.
Yeah.
I'm anxious. No, this is our strategic direction, and you have seen this before, to improve the culture of patient safety, to expand provider involvement. Again, we want to be less hospital-focused and more focused throughout the continuum, maintain a patient-family-centered care focus, supporting provider efforts with regard to the waiver requirements and initiatives, and then continue coordination with around statewide priorities with these specific agencies.
Thank you for the work that you do. It's very important, and progress in this direction to get at aspirational goals, as Chair was talking about, is extremely important. Thinking about for every individual patient who is affected by a medication error or an adverse event, it's not just a data point, it's a person. And so anything worse than perfect still affects somebody. So perfection is difficult, if not impossible, in some areas to achieve, but we should continue to strive toward protecting all patients. So thank you for the work that you do. With the strategic direction, there are a number of states that do report to the public about their safety initiatives, and sometimes helping hospitals who it may be new to them, but to see examples from other states where it has been done for years to share blinded information at the facility level that can help start that process toward involving the public and understanding where there are safety issues, that there is variation in safety and quality. It's very important. So again, it feels like this is the third year in a row that I know I have said something, and a number of other commissioners have said, please be more transparent with the results. I do have a question. As I look at your website, and I saw the maintain patient family-centered care focus, I saw nothing on the website about patient and family-centered care. So could you explain to me what that means in terms of a strategic direction?
Well, it means a lot of different things. It means, one, patient-family-centered care is part of our process as we go through in developing the initiatives, that focus is
how do you define that?
well, it takes on different dynamics with the different initiatives. We were working toward a patient-family-centered care bundle specific to really showcase this and to make it in the forefront. I will tell you, we fell short with our study group and our committee as far as participation. So we have had to go kind of back to the drawing board, which is why it's not listed here, but it's not something that we have forgotten, or I should say in the initiatives for fiscal 18. It is not something that we've forgotten about or that we are discarding. It just became a scheduling and a participation issue, but we still have interest from a corpus to make that happen. So we have every intention of making a specific patient family-centered care bundle part of what we're doing. The medication reconciliation is very much a patient-focused, patient education-related initiative, as is the opioid misuse. And then the neonatal abstinence syndrome is very much patient-focused. We bring families into the fold. We're talking to families about what we're doing. We're involving them in the discussion, part of the learning process with the hospital. Just a few examples there.
I was going to add, in our bundle, that's the C-section bundle, there's a whole section in there on the patient, involving the patient and family, like if there is a decision to do a C-section or use a traumatic emergency C-section, making sure there's some shared decision making and resources available. Neonatal abstinence, whenever possible, when we pull these groups together, if we can get a patient to tell their story, to take it, to make it personal, because it's so effective for healthcare providers to talk to somebody. You can get mired in the numbers and these quality improvement projects, but we talk all the time, such as tell the story, find a patient story when you're doing your case review. This was somebody's mother, somebody's wife, you know, make this case real, not just a case to review. So I can say that in all of our initiatives, and because I'm a nurse, I think I'm always thinking of that patient that got sick and died, and what happened to that family. So we make a concerted effort to find patients when we can.
We have come a long way as far as consumerism and involving patients and making it much more. We have still a ways to go, but we are making, I think, some significant inroads in that regard.
And I think we can improve our website. Yeah.
Thank you very much.
Thank you.
Ben, can you give us an overview of upcoming initiatives for next month?
Yes, thank you. So I did neglect to point out to the commissioners that we added a tab on the community side of the website, not the consumer side, but on the far left there's an additional tab regarding that's labeled, I think, transparency or industry transparency. I wanted Levon to pull it up, but I believe he's attending another matter right now. So if you go to the website, you'll see that tab, and it's really nothing new, but it's an attempt to consolidate a number of different reports, including the hospital occupancy report, which seems to be a high demand report on changes in the number of hospital licensed beds. It includes some of the work that David is doing in our work with CRISP that shows progress in diffusing use of EHRs and use of CRISP, which is critical to the ICN activities. It includes a link to the work that Linda's team is doing on utilization, cost and utilization, and that website. So it's not anything new, but it's in response to questions that we've gotten over time from industry largely, can be used by consumers, but where is this report or where is that report? And it's useful for tracking progress in the performance of the health system and what MHCC is doing with regard to monitoring it. So easy to pull up. In terms of next month, the meeting will be held on March 23rd. Teresa will be rolling out the next version of the healthcare quality report, which will reflect the most recent update of our own data as well as that provided by CMS. It will have some of the updates on recent EHR throughput on it, which I know is of interest to the Commission. David's team will update you with final reports on the round 2 of the telehealth awards. We'll, of course, have more information on legislation, and we will expect to bring back the cardiac surgery recommended decision for Baltimore Metro and the Upper Shore. So we expect to have a fairly lengthy meeting in March. We'll keep you abreast and share with you material as it comes forward. Thank you very much.
Thanks, Ben. If there's no other business, I'll entertain a motion to adjourn. Second. All in favor? Meeting adjourned.